Hello. Very good morning, my dear lovely friends. I hope you're keeping yourself safe and sound, and I hope that your journey in surgery is comfortable. So, today, beta, we'll be focusing right from the lumbar region downwards. Till yesterday, in adult surgical problems, we have discussed the stories related to this pharynx, that is Zenkus. We discussed about the esophageal stories, where we talked about eclasia cardia and other associated problems causing traffic jam situation in the esophagus. Then we talked about the stories of chest pain, the GRD, the complications of GRD, the Bohr-Havi syndrome, where we also talked about the iatrogenic esophageal perforation in various foreign bodies inside the esophagus. Then we moved down into the abdomen in the epigastric area. We talked about the stories of stomach and duodenum, how the gastritis can occur, how peptic ulcers can occur, how we have to deal with these problems, and what can be the complications when we are doing surgery for peptic ulcer, what can be the complications of peptic ulcer, what are Bezors, what is bariatric surgery, and so on. One of you, I'm really thankful to you. I think you reminded that we missed out somewhere in eclasia cardia. I think first investigation is barium swallow. And I feel that probably I did not write there. No, it is written. Okay, so thank you very much anyways. Then after the discussion of stomach and duodenum stories, we moved into the right hypochondrium, where we talked about the stories of liver and gallbladder, and the bread and butter for a surgeon, the gallbladder, where stones, how different type of stones can form, what these stones can do, how the patients can present to us, and how you, my dear lovely doctors, how you're going to approach your patients in February 23. Believe me, beta, just keep that fire inside your belly. Just keep that burning belly inside. Stay focused, stay concentrated. And you all are going to crack 17th of December. Keep that believing in yourself. You can just take a piece of paper and write the score what you want on 17th of December and keep that paper right in front of you wherever you are studying. Keep looking at that score every day, so that it keeps you pumping all the time that yes, I have to cross this, I have to cross this, I have to cross this. Whatever score you want for yourself, you can just stick that paper in front of you, so that, you know, if you crack the 17th of December, your life in 2023 will be absolutely different and you would be enjoying your life like anything. Day before yesterday night only, when we had some turbulences in the class, I went to one of the hospitals with someone in the night, and I was really thrilled to see our foreign medical graduate students doing a great job, how they're managing the entire emergency of a big hospital, wherein they were managing all the triage areas, the red zone, the green zone, the black zone, and everything, and how nicely they were taking care of the patients. It was really, really a thrilling pleasure for me to see you lovely people working in the hospital, right? Just a wait of 4 months and few days, and then life is really going to be enjoyable, right, beta? So coming back, the bread and butter of a surgeon, the right hypochondrium, the gallbladder stories, the stones, how they are managed, what can be the different other pathologies related to gallbladder, how the stone from the gallbladder can slip into the CVD causing problems, how the stone can slip into the pancreatic duct and causing pancreatitis. Okay. Right. Apart from this, we also talked about the chronic pancreatitis story. We talked about the liver abscesses, the pyogenic liver abscess, the amoebic liver abscess, and the hydrated cyst. And just a passing reference for that coffee bean sign or bird of prey sign regarding sigmoid volvulus, how the sigmoid volvulus can rotate around its mesentery and can lead to complications. We just put a flatus tube out there for 24 hours and the story can resolve. Right, beta? So now, today we'll be moving from the flanks downwards. Let me just switch it on. Just give me a moment, beta. I'm sorry. I'm sorry. I'm really sorry. I'm really sorry. I did it. I did it. I did it. Thank you, Viral. Thank you. Thank you. Thank you, beta. Thank you. Right. Thank you, Hinal. Thank you, beta. Thank you. Thank you. Thank you, beta. Thank you so very much. Okay. Let me just completely focus. Right. So here in beta, we are talking about why these stones form in the urinary tract. Let us, the audio was mute and I'm really thankful that you quickly reminded me. We are just trying to sort out that how these stones can form in the gallbladder that we talked about yesterday. Another common surgical problem are the urinary stones. Why these stones form in the kidney or maybe the bladder area. How different type of stones will form. What these stones will do to the patient. And when the patient comes to you with different problems, how you, boss, will approach your patients and treat your patients. So, beta, we all know that continuously our kidneys, they are filtering the waste material, the end products of cellular metabolism, urea, creatinine, they're continuously getting filtered from our urinary tract. The commonest reason for these stones forming is a idiopathic hypercalciuria. idiopathic hypercalciuria. First, we'll just try to understand, beta, that what is the whole story about. You would be surprised to know, beta, that even today morning, when you went for urination, you would have passed some tiny, very minute crystals in your urine, which you might not have recognized, which we'd never come to know about. That means continuously, beta, we are human beings, we are passing the waste products out. So we are passing those small, tiny concretions which we never come to know. But sometimes what happens, if the concentration of these calcium type of people or oxalate type of people or uric acid type of people or maybe phosphates, they increase in the urinary tract, then there are chances that these substances can precipitate in the urinary tract. And if they start precipitating in the urinary tract, they will lead to formation of stone. है ना बेटा? I repeat this in Hindi, बेटा. हम सारे लोग यूरिन जाते, यूरिन में हम क्या निकालते? जो भी हमारी बॉडी में सेलुलर मेटाबॉलिज्म के वेस्ट प्रोडक्ट्स हैं वो निकालते. तो ये हमारा जो यूरिनरी ट्रैक्ट है कंटिन्यूअसली हमारे इन वेस्ट प्रोडक्ट्स को बाहर निकालता रहता है और हमें कभी एहसास भी नहीं होता कि हम वो बहुत छोटे छोटे कंकड़ जैसे चीजें यूरिन में पास करते रहते हैं जो हमें दिखाई भी नहीं देते. लेकिन कोई भी ऐसे हालात जब इस तरह के जो कंक्रीशंस, जो कंकड़ जैसी चीजें हैं, अगर इनकी मात्रा हमारे यूरिनरी ट्रैक्ट में ज्यादा हो जाएगी तो ये कंकड़ हमारे यूरिनरी ट्रैक्ट में कहीं ना कहीं डिपॉजिट होना शुरू हो जाएंगे और वही पत्थर बन जाएगा. चूंकि since we keep on passing these products like calcium, oxalate, uric acid, phosphate, all that stuff, so there are chances of precipitation of these particles, and that can lead to different type of urinary stones like calcium oxalate stones. These are the commonest stones what we see inside the kidney. They can be monohydrate, dihydrate stones. Dihydrate are much more common. Monohydrate are hard stones. We can pass stones having triple phosphate. We can pass uric acid stones, cysteine stones, xanthine, indinavir, triamterene, allopurinol, and whatnot. Right? So this is how the different type of urinary stones occur. Apart from this concept, another concept what we know, beta, whenever there is a traffic jam situation, now you will say that what surgery sir is doing continuously in the class, he is just talking about traffic jam. Because surgery is nothing but a traffic jam. And what a surgeon is supposed to do is just to release the traffic jam. So just imagine, beta, we know that there is a kidney, there is a ureter, there is a bladder, there is urethra. If there is any traffic jam in the tract, the proximal people are going to get dilated, stasis, bacterial party, infection, urinary tract infection, UTI, stone formation. So this is also going to be a common cause of urinary stones. People who keep on immobilized for long periods. A bit of prolonged immobilization, dekho. How this prolonged immobilization word we have used at so many places. Concepts banana beta, है ना? Vascular surgery में, if there is slowing of the circulation, if there is slowing of the blood flow in the veins, then there was deep vein thrombosis, है ना? Yesterday we were talking about phytobazor. Whenever there is gastric stasis, whenever the person is lying for long periods, the motility of the intestine slows down. The same concept in the urinary tract. If the motility of the urinary tract slows down, that means if the peristalsis in the ureter slows down, there will be more chance of stasis, more chance of party, more chance of infection, more chance of stone formation, right? You can just try to correlate this, though we know that you have got a paucity of time because you are focused on 17th of December and we have to be really smart. But maybe after 17th of December, suppose you go out somewhere on a hill station or something, then just try, when you're all alone and just looking at the natures, you're just admiring the nature, just try to think your own body, what God has created inside. and just try to use these concepts and try to understand this human body. Because if you understand your human body nicely, then you will not be facing a lot of problems with your patients, right? Coming back, if you try to create a traffic jam situation in the urethra, for example, beta 60, 70, 80 years old gentleman, a common urinary problem is benign prostatic hyperplasia. There is a prostate gland just beneath the bladder neck. Now, if suppose the prostate gland enlarges, it will put pressure on the urethra and the urethra traffic jam will occur. So proximal bladder will get dilated, stasis, party, stone formation inside the bladder. Right? So this is how these urinary stones can form. Now, looking at these different types, these are spiky stones. Can you see the spikes? These spikes are going to cause injury to the urothelium, which can lead to bleeding. So these spiky stones, these are calcium oxalate stones. They have more chances of causing injury to the urothelium. So there are more chances of hematuria, right? Bleeding will occur in the urinary tract and that will lead to blood in urine. That is hematuria. So MCQ people can ask you, Bhaiya, out of these different type of stones, which stones have more chances of causing hematuria? So any stone what you're seeing in this, whether it is this stone, any spiky stone have more chances of causing hematuria. Right. These stones what you're seeing, beta, these are smooth round stones. They are uric acid type of stones. Then this type of stone which takes the shape of the pelvic calyceal system, isko dhyan se dekhiyega beta. This has been asked as a image based question in your exams. The stone which takes the shape of pelvic calyceal system, this is called as staghorn stone. Staghorn stone, right? Fine. Now let us see first what are the different types of urinary stones. Please do not miss out on this beta. This has been asked as an image based question. A stone which takes the shape of pelvic calyceal system, this is called as a staghorn stone. Now let's take a look what all is written here about the types of urinary stone, and then we'll discuss that how these patients will present to us. Right, beta. So most common kidney stone, that is a calcium oxalate stone, and in this calcium oxalate beta, you can just write in the bracket dihydrate. Calcium oxalate dihydrate. Most common urinary bladder, ये जो है ना बेटा, ये urinary bladder है. Most common urinary bladder stone. Here I would like to tell you, beta, urinary bladder stones are much more common in young age, boys. 10 times more common in boys, right? Many a times even you would have done that when you were very small, maybe around 6 years, 8 years, 10 years of age. Then what you used to do, you used to go to the school in hot summer, and when you came back from the school, you would have just put your bags in the house and you would have run outside the house and you would have been playing cricket or whatever. So at a young age, we are not that much focused about our hydration. So we keep on playing, and we do not hydrate ourselves properly. Those individuals who drink less amount of fluids, then the chances of these concretions getting deposited somewhere in the urinary tract are high. जो लोग पानी कम पीते हैं, उनमें ये जो कंक्रीशंस होते हैं, कंकड़ होते हैं, इनके यूरिनरी रास्ते में डिपॉजिट होने के चांसेस ज़्यादा होते हैं, right? Okay. So most common urinary bladder stone in boys, it is triple phosphate. Overall also, commonest urinary bladder stone will be triple phosphate. However, in adults, commonly we find uric acid stones. Now, why these stones are forming, beta? Most common cause is idiopathic. Idiopathic means when the cause is not known. Hypercalciuria. Hypercalciuria. That means we don't know why, but for whatever reasons, more calcium is being excreted in the urinary tract. Same way, beta, here we are talking about calcium. Here we are talking about oxalate, idiopathic hyperoxaluria. Here we are talking about uric acid, idiopathic hyperuricosuriia. So these are the common causes. Prolonged immobilization, urinary tract infections. We discussed better this UTI, urinary tract infections, how these urinary tract infections will lead to stone formation. Cranberry juice prevents UTI. What is the reason? We don't know, but there are so many hypotheses. One hypothesis say if you take cranberry juice, that makes the urinary mucosa slippery. So bacteria cannot attach itself to the mucosa if the mucosa is slippery. So probably that is the reason why cranberry juice can prevent UTI. Deficiency of vitamins, vitamin A. When vitamins are deficient in the body, then the integrity of the mucosa becomes weak, and then the concretions have more chances of getting deposited on the urinary mucosa. Even hyperparathyroidism, when more calcium would be coming into the kidney, that can lead to this. Even milk alkali syndrome can lead to this. अच्छा बेटा एक चीज बताओ, just tell me, urinary tract infection is more common in males or females? Very good, you all know that. चलो एक वीडियो देखते हैं बेटा. Let's just have a look at a video. Why UTI is more common in females? Though you know the reason, but still it is my duty, because this is something which is very commonly seen in practice.
A urinary tract infection, or UTI, is an infection in any part of the urinary system, the kidneys, ureters, bladder, and urethra. An infection of the urethra, or urethritis, may cause burning sensation when urinating and cloudy discharge. A bladder infection, or cystitis, may result in pelvic pain, frequent painful urination, and blood in urine. A kidney infection, or acute pyelonephritis, may cause back pain, possibly only on one side, high fever, chills, and nausea. UTIs typically occur when bacteria enter the urinary tract through the urethra and multiply in the bladder. Most commonly, these bacteria come from the digestive tract through fecal matter. UTIs are more common in women because of their anatomy. Specifically, the short distance from the anus to the opening of the urethra and bladder makes it easier for the bacteria from the digestive tract to reach the urinary system. This is why the most common UTIs occur mainly in women and affect the bladder and urethra. Other bacteria may be brought over with sexual contact. Women who use certain types of birth control, such as diaphragms or spermicidal agents, are more at risk. Hormonal deficiency during menopause also makes women more vulnerable to infection. Infection limited to the bladder can be easily treated with antibiotics. However, if left untreated, a lower urinary tract infection may spread up to the kidneys, where it becomes more dangerous. A kidney infection may result in permanent kidney damage. In rare cases, an infection may also spread to the bloodstream and can be life-threatening. Urinary tract infections can be prevented following these steps. Drink plenty of fluids to flush out bacteria more frequently. Wipe from front to back after a bowel movement. This helps prevent bacteria in stools from spreading to the urethra. Empty the bladder soon after intercourse to flush bacteria. Avoid feminine products such as douches and powders, which could irritate the urethra. Avoid diaphragms and spermicides as birth control methods.
Right, beta. So this was just a glimpse why UTI is more common in females. One, we know the distance between the rectum and the urethra in females is much less as compared to males. And second, it is a very short urethra in females, so the infection can easily ascend into the bladder. These are the common reasons why UTI is more common in females.
A urinary tract infection, or UTI, is an infection in any part of the
Right. Now, if we take a look at the different types of urinary stones, beta, the calcium oxalate, they can be monohydrate or dihydrate. Most common is the dihydrate. Monohydrate is the second hardest stone. Generally, the calcium oxalate stones, they are seen in normal urinary pH. Normal urinary pH. And the normal pH of urine, beta, it is between 6 to 8, but generally it is around 6. That means urine is slightly acidic. This is something which is normal. Yesterday, beta, if you remember, we talked about pH inside the esophagus is 5 to 7. pH inside the stomach is strongly acidic, 1.5 to 2 or maybe 2 to 3. The calcium oxalate stones are speculated and they cause hematuria. Triple phosphate stones, they are composed of calcium, ammonium and magnesium phosphate. They occur in alkaline urine, especially when the patient is having UTI. And the commonest cause of UTI is E. coli. Apart from E. coli, there are Proteus, Klebsiella type of microorganism which cause this UTI, and they split urea into ammonia. So these are urea splitting bacteria, especially if we talk about Proteus. And we know yesterday when we were talking about H. pylori, how it used to survive inside the strong acidic environment of the stomach because it was producing urease. So urea was split into ammonia and that created an alkaline environment around this bacteria inside the stomach. Since more alkali is produced, so obviously this is going to stimulate more acid inside the stomach. Apart from H. pylori, there are various other bacteria which can split this urea like Proteus and Klebsiella, and to some extent even E. coli at times. So if somebody is having infection with Proteus, then huge amount of alkali is going to be produced and that will make the urine alkaline, right? So commonly in UTI patients, we find the urine to be alkaline. These triple phosphate stones, they are the most radio opaque stones. That means these are the stones which are most nicely visible on X-ray. They can also be referred to as true white stones. They usually remain silent. जो लोग ज़्यादा चुप रहते हैं वो ज़्यादा खतरनाक होते हैं. People who remain silent, they are more dangerous. So what can happen, beta, if we just try to understand here? Just have a look here. If suppose I say that there is a stone which has started developing in the kidney, and suppose this stone is not causing any problem to the patient, then this stone will keep on enlarging, and a stage will come when this stone will take the shape of the pelvic-calyceal system. And if the stone takes the shape of pelvic-calyceal system, that stone is what we call as the staghorn stone. Right? So this is how these triple phosphate stones have more chances of converting into a staghorn stone. I hope you are able to appreciate this nicely, that how this stone has taken the shape of the pelvic-calyceal system. Right. This is what we can see, and this is what is a staghorn stone, which has been asked as an image-based question. Those stones which remain silent, they can take the shape of the pelvic-calyceal system, and then we call them as staghorn stone. Staghorn stone. Another type of urinary stones are the cystine stones. Obviously, those patients who are having cystinuria, they will have more chances. The urine is acidic. These are the hardest stones. These are the hardest stones. The second hardest stones are calcium oxalate monohydrate. Cystine are the hardest stones. Since they are very hard, it is difficult for the shock waves to break these stones. So they are difficult to be broken by shock waves. They are difficult to be broken by shock waves. The other type of stones like uric acid, they are smooth, round or oval in shape, obviously seen in patients with uricosuriac, acidic urine. and they are radiolucent. That means since they do not have calcium, they are not visible on X-ray. Again, beta, we know what are the different stones which are not visible on X-ray. They are remembered by the mnemonic PG में जाएंगे, लक से नहाएंगे. Right? So PU is for parotid, G is for gallbladder. Yesterday we talked about beta that gallbladder stones. Gallbladder में क्या होता है? Gallbladder has got bile, and bile is responsible for emulsification of fats. So there is cholesterol inside the gallbladder and not the calcium. Since the gallbladder stones have got cholesterol and not calcium, that is why they are not seen on X-ray. Herein, before we move forward, just reminded me of a question yesterday that why regular striated and gallstone ileus? Why we see a stone on X-ray if gallbladder stones are radiolucent? That was absolutely correct. Generally, we do not see the gallstones on X-ray. So regular striate is not always seen in gallstone ileus. It is rarely seen in gallstone ileus. Multiple air fluid levels and air in the gallbladder is something what you will see. But stones in the intestine on X-ray, that is rarely visible. So that statement is correct. Now, porcelain gallbladder is a condition where there is deposition of calcium inside the gallbladder. That is seen on X-ray. Na? Same way in the salivary stones, beta, submandibular duct stones are seen on X-ray, but parotid duct stones are not seen on X-ray. Okay, and here, beta, lux we mentioned about lysine, uric acid, and xanthine. All these are urinary stones, and they also do not have calcium. They are not visible on X-ray. Right. Other type of urinary stones, xanthine, lysine, indinavir, triamterene, and allopurinol. They can be seen. Suppose somebody is taking allopurinol for a long period of time. Then allopurinol medicine, that can get deposited in the urinary tract and can lead to a allopurinol stone. Right? Indinavir, which is commonly used in HIV patients. Right? That can also form a stone in the urinary tract. Right. Now, how these patients actually present to us, beta? For that, I think, let us just try to take a look. If suppose I say that this is the kidney, and in the kidney, beta, we know there is a pelvic-calyceal system. Suppose I say these are the minor calyces. These are the major calyces. This is the renal pelvis. And this down is the ureter. Suppose this is the renal pelvic-calyceal system. Renal pelvis, and then this is the ureter. This ureter is going down, and here would be the urinary bladder. And then down will be the urethra. Something like this. Right, beta? Now we'll just try to create a situation where a stone has formed inside the urinary tract. What will happen to the patient? Look at the screen carefully, beta. Whenever there is a stone getting formed, maybe here, maybe here, maybe here, maybe here, all these will be kidney stones. This will be a ureteric stone. We can classify this into upper ureter, middle ureter, lower ureter. Then this would be a bladder stone here, and this would be a urethral stone, right? Now, if suppose I say that a stone has started forming here, what will happen to the patient? This stone is going to cause some irritation in the urinary tract, right? So that irritation in the urinary tract will irritate the patient, give a irritative feeling to the patient that there is something inside and he would like to get rid of this something inside. For this, he would be going for frequent urinations. That means frequency of micturition. That is going to be the earliest symptom. But this frequency is not disturbing his life so much that he is forced to come to the hospital. So, earliest symptom for urinary stones is frequency, but patients do not come to the hospital with frequency of micturition. Majority of these patients, what happens, beta? This stone is actually creating a problem, a traffic jam type of situation. Now, this is going to cause severe pain, and this severe pain forces the patient to come to the hospital. So the commonest presenting symptom is pain, and where the pain is located, that depends on where the stone is located. Like if the stone is in the kidney, then patients present with fixed lumbar pain. For example, if we just try to take a look at one of the images here, that is how majority of patients will come to you, beta. Can you appreciate this? If you carefully take a look here, just to see the thumb in the front and 4 fingers at the back, or maybe 4 fingers in the front and thumb at the back. That means February 23, majority of patients would be coming to you with something like this, either like this or like this. This is what we call as the lumbar pain. Majority of patients present to us with this type of presentation. When you are sitting in the emergency of the hospital and you see a patient coming to you, entering the emergency with hand like this, just by looking at the position of the hand, you will be able to get the idea, ki boss, this is a case of urinary stone, right? This is the commonest presentation. Now, depending on the location of the stone, the site of pain may vary. For example, if I say that there is a stone in the kidney, then patient presents with fixed lumbar pain. If suppose I say that this stone comes down in the upper ureter, then the lumbar pain radiates downwards. It radiates towards the perineum in females and testis in males. If suppose the stone comes further down, suppose the stone comes here at the pelvic brim. Now pelvic brim is the area which is the junction of upper ureter and middle ureter. Actually the pelvic brim is the pelvic inlet where the pelvic bone starts. That is the pelvic brim, right? This stone here, the patient presents with lumbar pain radiating to the inner aspect of thigh. If the stone slips further down and comes in the middle ureter, then the lumbar pain radiates to the corresponding iliac fossa. If it is a right middle ureteric stone, the lumbar pain radiates to the right iliac fossa. If it is a left middle ureteric stone, the lumbar pain radiates to the left iliac fossa. If the patient comes to you with pain in the right iliac fossa, you start thinking, ki boss, this can be a case of acute appendicitis. So if the stone is in the right middle ureter, that can present with lumbar pain radiating to right iliac fossa, mimicking acute appendicitis sometimes. Okay? If the stone slips further, and suppose now the stone comes in the lower ureter, and the lower ureter is here. Now, if there is a stone in the lower ureter, this stone will keep on irritating the bladder, and the patient will have a strangury type of feeling. That is a painful desire to pass urine with passage of very little amount of urine. So a stone in the lower ureter or intramural ureter. Intramural means, mura means muscle. That part of ureter which is lying in the muscle of the bladder, that is intramural. Okay, if there is a stone here, it gives a painful desire for passing urine, but maybe only few amount of drops of urine are coming out. Okay, I repeat better. Depending on the location of the stone, if the stone is in the kidney, fixed lumbar pain, upper ureter, lumbar pain radiating to the perineum in females and testis in males, pelvic brim, that is the junction of upper middle ureter or the area of pelvic inlet from where the pelvis starts. If there is a stone here, lumbar pain radiate to the inner aspect of thigh. If the stone is in the middle ureter, the lumbar pain radiate to the iliac fossa. If the stone is in the intramural ureter or lower ureter, there is painful desire to pass urine, strangury. Now, if the stone is inside the bladder has got huge space. So generally, bladder stones are big in size. If there is a stone here, then the patient will present not with lumbar pain. ये नहीं होगा बेटा, पत्थर यहाँ है तो दर्द भी यहाँ होगा, right? So if there is a stone in the bladder, patient will have suprapubic pain, right? Sometimes what happens, this stone tries to slip when the boy will pass urine, right? The urine is coming down, the stone might be coming down. If the stone comes at the bladder neck, there can be interruption of urinary stream. Just imagine beta, a 5-year-old boy who was passing urine at the roadside. He was passing urine normally, but just imagine he has got a stone here. As he is passing urine is going down, the stone is going down, and suddenly the stone comes at the bladder neck and the urine stops. And if the boy starts looking here and there, what happened? Why this has stopped? Who has come? Is there any witch or something? And then the boy is not able to understand. The boy just tries to change the posture. And by changing the posture, he might be able to displace the stone and then he will pass the remaining amount of urine. So this type of story can be cooked on 17th of December. 5-year-old boy who was passing urine at the roadside normally, suddenly the urine stops. What can be the reason? Interruption of urinary stream. Why? Because of a large bladder stone may cause traffic jam at the bladder neck. Right? I repeat this in Hindi beta. This has been asked in the FMG exam. There are 2 clinical situations which we are discussing right now. One we are discussing here. ब्लैडर में जो पत्थर होते हैं ना बेटा, वो बड़े होते हैं क्योंकि ब्लैडर में जगह ज़्यादा है तो आसानी से ये पत्थर एक्सपैंड कर सकते हैं. अब ब्लैडर के जो पत्थर है वो छोटे बच्चों में ज़्यादा कॉमन होते हैं, बॉयज़ में ज़्यादा कॉमन होते हैं. अगर बड़ा पत्थर है ब्लैडर में, 5 साल का छोटा सा बच्चा सड़क किनारे कर रहा था, यूरिन कर रहा था, करते करते अचानक उसकी रुक जाती है और वो इधर उधर देखने लगता है कि ये क्या हुआ, कौन आया, भूत आया, कौन आया, क्यों रुक गई है. फिर पता नहीं क्या होता है बच्चे को. बच्चा अपने आप ही अपना पोस्चर जो है थोड़ा सा चेंज करता है. पोस्चर चेंज करने से हो सकता है कि ये पत्थर डिस्प्लेस हो जाए और फिर बच्चा बाकी का यूरिन निकाल दे. राइट? तो ये एक कहानी बन के आ सकती है. Another thing बेटा, when this stone is slipping down, if it comes at the bladder neck, or maybe if this comes into the urethra, then the suprapubic pain is referred to the tip of penis. 5-year-old boy who was passing urine at the roadside. Suddenly he starts crying, screaming, shouting and is pulling his penis. What does this mean? This simply means that the boy was having a stone inside the bladder, which has suddenly come at the bladder neck or maybe in the urethra. 5 साल का छोटा सा बच्चा सड़क किनारे यूरिन पास कर रहा था. अचानक करते करते वो जोर जोर से रोने लगता है, चिल्लाने लगता है और अपने पेनिस को पुल करने लगता है. इसका क्या मतलब है? ब्लैडर के अंदर पत्थर था जो जैसे ही ब्लैडर की नेक पे आया, सुप्रा प्यूबिक रीजन में जो दर्द था वो उसके पेनिस में जाना शुरू हो गया. इसलिए वो जोर जोर से रो रहा है, चिल्ला रहा है. Right? So these can be the different presentations. Apart from this beta, we can understand wherever the stone is in the urinary tract, This stone might cause injury to the urothelium, which can lead to bleeding. And bleeding in the urinary tract, the baby will pass blood in urine. That is hematuria. Okay? I hope you got the concept of presentation of these urinary stones. Right. So most common presentation आपकी मुलाकात कैसे होगी बेटा इन urinary stones वाले patient से? Hospital में they will present with pain. However, earliest symptom in majority of urinary pathologies is frequency of micturition. कारण कोई भी हो, चाहे पत्थर हो, चाहे सिर्फ इन्फ्लेमेशन हो, चाहे कोई पॉलिप हो, कोई ट्यूमर हो, reason may be any, whether it's a stone or simple inflammation like UTI or maybe a polyp or tumor in the urinary tract, it will irritate the urinary mucosa, which will give irritative feeling to the patient that there is something inside, and to get rid of that something, the patient would be going for frequent micturations. Apart from this hematuria and interruption of urinary stream, this interruption of urinary stream is seen in cases of large bladder stones, large vesical calculus. Now, beta, please do remember that the two examples what we have discussed, both these examples have been asked in your exams. So you will be writing those examples in the language you best understand. 5-year-old boy passing urine at the roadside, suddenly the urine stops. This is interruption of urinary stream in large bladder stone or large vesical calculus. Vesicle is the term used for bladder and calculus is stone. 5-year-old boy who was passing urine at the roadside, suddenly he starts crying, screaming, shouting and is pulling his penis. It means that the stone in the bladder is slipping down towards the bladder neck or maybe into the urethra. If we talk about the presentation of pain in the urinary stones, depending on the location of the stone. For example, if I just remove this, now depending on the location of the stone, if the stone is in the kidney, then the patient will have fixed lumbar pain. If the stone comes in the upper 1/3 of ureter, then the lumbar pain radiate to perineum in females and testis in males. If the stone comes at the pelvic brim, then the lumbar pain radiate to the inner aspect of thigh or inner thigh. If the stone slips and comes in the middle 1/3 of ureter, then lumbar pain radiate to the iliac fossa. Right, beta? And please do remember, if the pain is in the right iliac fossa, it may mimic acute appendicitis, right? So a right middle ureteric stone may mimic acute appendicitis. If the stone is in the intramural ureter, then these patients will present with strangury, which is a painful desire to pass urine. If the stone is in the bladder, the patient will present with suprapubic pain. If the stone slips and comes at the bladder neck or in the urethra, then the suprapubic pain is referred to the tip of penis. So that is how, depending on the location of the stone, the patient can present to you, beta. And just by seeing the patient, just by looking at the patient, if you know this story, you can make out what can be the site of urinary stone in this patient. Obviously, in our clinical approach, when these patients come to you in the hospital, the pain is very severe. If you ask these patients to sit on the stool, they are not even able to sit on the stool because of severe pain. If you ask them to lie on the bed, then even in the bed, they are not able to lie still. They are continuously tossing in the bed like this. The pain is very severe. So as a doctor, beta, our first thing is to relieve the pain. So the first medicine what we give to these patients is diclofenac. We can even use tamsulosin. Tamsulosin causes relaxation of the muscles, relaxation of the sphincter. So it can just relax the spasm, just relax the lumen so that the pain can decrease. First investigation what we can do in these cases is a simple X-ray of kidney, ureter and bladder, or ultrasound of kidney, ureter and bladder. KUB, this is kidney, ureter and bladder. Since 80 to 90% of urinary stones are visible on X-ray. So if you take a plain X-ray, beta, you can see the stone somewhat like this, right? You can appreciate the stone like this. If you're not able to see the stone on X-ray, you can do a ultrasound also. But the investigation of choice for urinary stone would be a non-contrast CT scan. Non-contrast CT scan. Why non-contrast, beta? The simple reason, this is the CT picture what you're seeing. This shadow is the kidney shadow. This shadow what you're seeing, this is the kidney shadow. Now here you are seeing a hyperdense shadow. Can you see this white shadow here? This is the hyperdense shadow what you're seeing, right? Now this is the non-contrast CT. If we give contrast in this patient, beta, look at the screen. If we give contrast in this patient, what will happen? The contrast would be filling this area something like this. The contrast is filling this area something like this. Though the contrast would be filling outside the stone. पत्थर के अंदर नहीं जाएगा contrast. Just look at the screen, beta. The contrast is going around the stone. It is not going inside the stone, right? Now, what do you actually see? The contrast has not gone inside the stone. The contrast is around the stone only. But the contrast and the stone, they have got the same density. So you will not be able to identify whether there is a stone or not. That is the reason why we do not use contrast to see the urinary stones. If we don't give the contrast, then the stone can nicely be seen something like this, right? Once the diagnosis is made, then what we are supposed to do, beta, these are some more pictures. This is a picture of a bladder stone, X-ray KUB showing a nice stone inside the bladder. We know that bladder stones are quite large. This is a cystoscopic image. If you pass an endoscope through the urethra into the bladder, you can see the stones inside the bladder like this, okay, on endoscopy. We know, beta, we have been doing endoscopies like anything till now since we talked about the upper abdominal areas. So we know for the stomach, duodenum area, we were doing a upper GI endoscopy, also for the esophagus. For the right hypochondrium, for the biliary channels, we were doing a ERCP, endoscopic retrograde cholangiopancreatography. If we go into the urinary tract also, beta, you can pass an endoscope into the urethra, urethroscopy, that endoscope into the bladder, cystoscopy. You can pass a special type of endoscope which can be passed through the urethra, bladder and into the ureter, uretroscopy. If you are passing an endoscope percutaneously into the kidney, then that is a nephroscope, nephroscopy. Okay, fine. Now, what we want to do in the treatment for these urinary stones, it is very simple, beta. We have to just get rid of these urinary stones. So, in order to get rid of these urinary stones, if suppose right? If we are doing endoscopy, we are passing the endoscope here. If you're just visualizing the urethra beta, this is urethroscopy. If you take the endoscope into the bladder and seeing the bladder, sorry, this is the cystoscopy. If you are using a special type of endoscope, which you can take into the ureter. For example, you know the ureteric orifice would be somewhere here. So you can take the endoscope into the ureter. This is a ureteroscopy, right? And if by chance you are passing an endoscope through the renal parenchyma into the pelvic ileal system from outside, that would be a nephroscopy. So this is how endoscopy can be done in the urinary tract, right? Now suppose I say that there is a stone inside the urinary tract. Suppose there is a small stone in the urinary tract, maybe say less than 5 millimeter in size. Now just look at this beta. This is a very small stone in the urinary tract. We should know that if this stone is less than 5 millimeter in size, the diameter of ureter is 6 to 8 millimeter. That means this small stone can pass spontaneously here. This can pass through the bladder also. The diameter of urethra is also 6 to 8 millimeter. That means if there is any stone in the urinary tract which is less than 5 millimeter in size, it can pass spontaneously in urine. No active intervention is required. There are a lot of Neem Hakim Babas sitting outside in the market. If suppose somebody is diagnosed with a small stone in the urinary tract, if he goes to the Baba and the Baba comes to know that this is less than 5 millimeter, he will just give some XYZ medicine and he will tell the patient that yes, for sure, I will remove the stone. Actually, the diameter of ureter and urethra is 6 to 8 millimeter. So these small stones, they'll pass spontaneously in urine. So when these patients come to us, we just encourage these patients to take plenty of fluids. Pani khub pijiye. Anything which can cause flushing of the urinary tract. Now we all know that beer, alcohol, that also causes urination, right? So we are doctors, we cannot advise the patient to take all this stuff. But patient knows that if there is a stone in the urinary tract, then by drinking all this stuff, the stone can pass. So patient asks you, the doctor, I have come to know from someone that if I take beer, then this might help in removing my stone. Then you can be just like, okay, if you want to take it, take chilled beer, take chilled beer. That will increase the pressure nicely. That will generate more amount of urine, right? So if you are in air conditioning environment and you're feeling cold, then you pass more amount of urine. But if you're in a hot environment, the fluid is getting lost through sweat, right? So if the moral of the story, if the stone is less than 5 millimeter in size, it can easily pass out in urine with plenty of fluids, right? But if the stone is more than 5 millimeter in size, then we have to get rid of the stone. And beta, how we can get rid of the stone? Very simple. Suppose this is a bigger stone here. Now what we can do is we can fire the shock waves. We can fire the shock waves from outside and they will break the stone into small fragments, and then the patient will pass these fragments in urine. For example, if you take a look at that particular image where the shock waves are fired, like in this particular image beta, what you are seeing here, there is a stone in the kidney, right? So we are just going to fire the shock waves from outside. These shock waves are going to break the stone into small fragments. This is how the stone is broken into small fragments. And if the diameter of these fragments is less than 5 millimeter, and the distal tract is patent, then these fragments will automatically pass in urine. When these small fragments are coming into the ureter, they form a line in the ureter. Alignment of these stone fragments in the ureter just in a uniform line. This is called as Steenstrasse phenomena. Steenstrasse phenomena. That's a road somewhere in Switzerland, right? Okay. So that is how we can make these stones pass out. This is actually the ESWL setting, right? There's a C-arm, which this is the ultrasound what you're seeing here. We can just focus the shock waves in such a way that if you press the button, when the shock waves are going to come out, they should hit the stone directly. We cannot keep firing these shock waves multiple times because these shock waves will cause damage to the surrounding organs also. Also, my dear friends, we cannot use these shock waves to break the gallbladder stones. The simple reason is, if you look at the gallbladder beta, suppose this is the liver and here is the gallbladder. The diameter of cystic duct, if you take a look, the diameter of cystic duct is just 1 millimeter. So if there is a stone inside the gallbladder, and if you break this stone by shock waves, it will be broken into small fragments. But the diameter of the cystic duct is 1 millimeter to 3 millimeter. So even if you break these stones, it is not practically possible to break the stones to less than 1 millimeter in size. So these stones are going to get arrested here. Plus, if they come into the common bile duct, they can create a traffic jam situation which can lead to severe cholangitis, Charcot's triad and Raynaud's mentard. So that is the reason why we do not just break these gallbladder stones by shock waves and treat. Why we remove the gallbladder for gallbladder stones? Because these stones are the commonest cause for gallbladder cancer. They would have caused chronic irritation to the gallbladder mucosa, and even if suppose you remove the stones but you leave that injured mucosa here that has been irritated, so it can lead to cancer. The commonest reason for gallbladder cancer are the stones inside the gallbladder. So just by removing the stones, you are not decreasing the chances of gallbladder cancer. Plus, there would be recurrent chances of gallstones if you leave the gallbladder inside. So for gallbladder stones, the treatment is removal of the gallbladder, that is cholecystectomy. But for urinary stones, we can use these different options. The best option what we have is something where we don't have to make any incision. We just have to focus the shock waves directly onto the stone, and the stone is broken into small fragments. If the fragment is less than 5 millimeter in size and there is no distal obstruction, it will pass spontaneously in urine. That is the treatment of choice. Sometimes what we come across, beta, sometimes there may be a large stone inside the kidney. If suppose the size of the stone is more than 1.5 centimeters, if suppose I say it is a bigger stone more than 1.5 centimeter, now if you're trying to break the stone by shock waves, there is a possibility that one of the fragments may be more than 5 millimeter in size. अगर बेटा अपन 1.5 सेंटीमीटर से बड़े किडनी के पत्थर को शॉक वेव से तोड़ने की कोशिश करते हैं, तो हो सकता है जो पत्थर टूटेगा उसमें से एक आध फ्रेगमेंट भी अगर 5 मिलीमीटर से बड़ा हुआ तो ये अटक सकता है. इसलिए that is the reason why stones which are more than 1.5 centimeter in size, we avoid using shock waves, because a fragment, if it is more than 5 millimeter, it will stuck in the urinary tract and can create a traffic jam situation in the urinary tract. For these situations, beta, we do a PCNL. PCNL is percutaneous nephrolithotomy. In this PCNL, what we are doing is, the concept is, we are going to make a small incision in the skin here, and then we'll create a tract right up to the kidney. The patient is lying in a prone position, right? You are going posteriorly, just below the 12th rib, okay? So when you are making a cut here, you create a tract up to the kidney, and then you can pass a nephroscope from outside. This what you're seeing is the nephroscope beta, right? So you're just passing the nephroscope from outside, and then you go through the kidney. There are the stones here, and then you can remove these stones. We know that we can use various energies also when we have to break the stones. That is lithotripsy. We can use carbon dioxide gas, holmium laser. We can use mechanical lithotripters which vibrate at a frequency of 55,000 cycles per second, right? So these are the various energies which can be used to break the stones, whether you are doing a PCNL or you are doing a ureteroscopy or anything, right? So for larger stones, for kidney, we prefer doing a PCNL, percutaneous nephrolithotomy, right? If suppose I say that there is a stone in the, if there is a stone in the ureter, suppose, now what should be done for this ureteric stone beta? I think you all know that nicely, right? क्या करेंगे बेटा एक बार बताओगे? If there is a stone in the ureter or lower ureter like this, yes, so you will be passing an endoscope into the ureter. This here would be the ureter. So you pass this endoscope, and now through the side channel of this endoscope, you can pass the Dormia basket. You take the Dormia basket here. I'm sorry, I use the same color. Let me change the color of this. You are passing the Dormia basket here. Take the basket around the stone. Open the basket. Withdraw the basket, and the stone will be caught within the wires of the basket. That is how we can remove the lower ureteric stones. This is ureteroscopic retrieval of stone. If we take a look at one of the images of this ureteroscopy, so here beta what you see, we have passed a ureteroscope right into the ureter, and then we can either use different type of instruments like a basket. What you are doing is, this is a special type of instrument beta which is passed through the stone, and there is a vibrator here, so it can break the stone, and there is a umbrella type of thing what you are seeing here, so that when you are disintegrating the stone, the fragments only come down. The fragments that should not go up, they are protected by the umbrella. So this is another way of treating the stone. This is the Dormia basket what we have been talking about. This is how we can catch the stone in the Dormia basket, right? Okay, G. If suppose I say that there is a stone in the urinary bladder, very simple. If we are talking about a bladder stone beta, I'm not able to rub this part because as soon as I rub this, okay, let me just rub this because you have got the concept already, right? Yeah, I think this is fine. Now we are talking about a bladder stone. Bladder stones are usually big stones. What we can do, simple method, we can pass an endoscope into the bladder, that is a cystoscope, And through the side channel of the cystoscope, we can pass some instruments which can break the stone. And if you are able to break the stone into small fragments, then if you are able to break the stone into small fragments inside the bladder, then these fragments will automatically pass in urine. So this is called as litholapexy. Litholapexy, something like this. Yeah, we are actually using this cystoscope. This what you're seeing is a cystoscope. And through the side channel of the cystoscope, we are just breaking the bladder stones. This is the cystoscopic view, and we can break the bladder stones, and that is how these stones can pass out. Right, so these are the common modalities what we are using in the treatment of urinary stones, and I'm pretty sure that all of you have got this concept nicely, that how to treat the salivary stones, how to treat the gallbladder stones, how to treat the urinary stones, right? For a stone which is less than 5 millimeter in size, nothing, just plenty of fluids. If the stone is more than 5 millimeter in size, then the treatment of choice is ESWL. Yeah, ESWL we have written somewhere here, extracorporeal shockwave lithotripsy, which is already written down. Treatment of choice for kidney upper middle ureteric stone is ESWL. Treatment of choice for lower ureteric stone is URS. This is ureteroscopic retrieval of stone using Dormia basket. So beta Dormia basket we have used in the submandibular duct stone, we have used in common bile duct stones, we have used in the ureteric stones using Dormia basket. Treatment of choice for bladder stone is litholapexy. We pass a cystoscope and we break the bladder stone. For urethra stone, if the stone is in the urethra beta, it is better, just have a look here. Suppose there is a stone in the urethra. Now, what we try to do is, we pass our endoscope and we just try to push the stone back into the bladder. We just try to push the stone back into the bladder and then treat it like a bladder stone, because it is difficult to break the stone inside this urethra. So a better option is just take the stone up into the bladder and then break the stone inside the bladder. So for a urethra stone, we just push the stone into the bladder and then treat like bladder stone. For more than 1.5 centimeter kidney or upper ureteric stone, we know that if we use the shock waves, the fragment may be larger than 5 millimeter and that can get stuck. So for these type of stones, we prefer doing a PCNL. PCNL is percutaneous nephrolithotomy. Percutaneous nephrolithotomy. Most common complication of PCNL is bleeding, because you are passing the endoscope through the kidney, and you know 3 solid organs in your abdomen, liver, spleen and kidney, they are full of blood. Whenever they are getting damaged, there can be profuse bleeding. Apart from this, in PCNL we are going through the 12th rib approach, And if you look posteriorly at the level of 12th rib, you can find a pleural border there. We know that the lower border of the lung versus lower border of pleura, 6, 8, 10 is the lung lower border. Pleural lower border is 8, 10, 12, right? So when we are going through the 12th rib approach, we might cause injury in the pleura, and since we are going to use fluid, there may be collection of fluid in the pleural cavity. Hydrothorax can occur. Because of bleeding from the kidney parenchyma, there might be blood getting collected in the pleural cavity. Hemothorax can occur. Also, when we are doing this PCNL from the left side, there is a risk of injury to the spleen or sometimes to the colon, right? But usually injury to the lungs will not occur in PCNL because the lower border of the lung is lying at 10th rib. Lower border of the lung 6, 8, 10, lower border of pleura 8, 10, 12. So if you look posteriorly, lung lower border is at 10th, pleura lower border at 12th rib level. So there won't be any chance of injury to the lungs. This bleeding, apart from this beta, there can be risk of injury to pleura, colon, spleen, but not lungs. When we are saying pleura beta, then this can even cause hydrothorax, hemothorax. Right, beta? So this is about the story of PCNL. Some points about ESWL beta. This is extracorporeal shockwave lithotripsy. In this, shock waves are fired directly onto the stone so that the stone is broken into small fragments which align in the ureter. This alignment of ureter is called as Steenstra's phenomena. And then, if there is no distal obstruction, then these stone fragments will pass spontaneously in urine. Again, beta, most common complication of ESWL is bleeding. ESWL should be avoided if there is more than 1.5 centimeter stone. ESWL should be avoided in pregnancy because there are 2 lives involved. There may be damage to the fetus. ESWL should be avoided in patient having bleeding disorders or bleeding diathesis, because if the shock wave causes some injury and patient is having some coagulopathy, because of which if there is bleeding and the blood does not stop, then there can be a major challenge. Any distal obstruction, if there is traffic jam in the ureter or maybe in the urethra, then also you should not do shock wave treatment because the fragmented stones will get stuck above the traffic jam. Cystine stones, these are the hardest stones. They are difficult to be broken by ESWL. So we avoid doing ESWL in these different situations. Right, beta? Okay. Another thing, beta, let me just mention about emergency urinary obstructions. Sometimes we come across emergency situations, emergency urinary obstruction treatment. Though I know that you know this concept nicely, but if suppose Very simple, and you all know this, but just it is my duty, so I have to tell this. If I say, beta, that there is a traffic jam in the urethra, right? If there is a traffic jam in the urethra, will the urine be coming down? Suppose I say there is someone who is creating a traffic jam here. Now the urine is not going to come down. So what will happen, beta? The proximal people are going to get dilated. So all this proximal story is going to get dilated, right? The patient will have retention of urine. In these cases, we can understand how troublesome this retention of urine would be. If this patient comes to you in February 23, say 2 o'clock in the night or 3 o'clock in the night with retention of urine, what simple treatment we can do, beta? We can just pass a Foley's catheter. We can just pass a Foley's urethral catheter. As soon as this catheter goes into the bladder, the urine will start coming out and the patient will be relieved. So, if we are talking about a traffic jam situation in the urethra, then what we can do is, first thing, we can try passing a urethral catheter. If that is successful, wonderful. If there is any challenge in passing the catheter from below, then you can just pass a catheter from above. That is called as suprapubic cystostomy. Suprapubic cystostomy. Okay, beta. So what I'm just trying to tell you, a basic thing. 17th of December, the examiner may create situations for you. That patient is presenting with retention of urine. Now, in these cases, to relieve the retention, the first thing is pass a urethral catheter. If you're not able to pass that, then you can just make a small cut in the suprapubic region, and the pen which you're holding right now, you can just put that. No, don't put the pen like this, but there is a special catheter which is called as supracath. We can just pass that catheter from above under local anesthesia, and it can go into the bladder and the urine comes out and the patient retention is relieved. So for lower urinary tract obstruction, my dear friends, we have the option of doing a Foley's urethral catheterization or suprapubic cystostomy. Same way, now if we try to imagine the upper urinary tract obstruction, we have the option of passing a catheter from below. Like if you are putting a stent into the ureter here, that is called as endourinary stenting. Endourinary stenting. For example, if I say there is a stone which is causing a traffic jam situation in the ureter here, you can try passing a stent from below, and this stent is actually a double J stent. We pass a stent across the obstruction like this, and the stent is having a coil here and a coil here so that the stent do not migrate. That is a double J stent. This can be passed with the help of an endoscope, right? This is called as endourinary stenting. Just what we were doing in the biliary channels, beta. CBD में अपन ने किया था ना. If there is a complete traffic jam, cholangitis, Charcot striate, Raynaud's pentad. So we were just doing a ERCP and stenting. Same way for upper urinary tract obstruction, beta, we can do this endourinary stenting. Or if you're not able to pass a stent from below, then you can try passing a stent from above. That means you can just pass a stent like this, okay, from above. This is called as percutaneous nephrostomy. So if you're not able to pass a catheter from below or a stent from below, then you can pass a stent from above, and this will be called as percutaneous nephrostomy. So moral of the story, beta, हमने क्या सीखा है? In emergency situations, when there is a complete traffic jam situation, proximal dilatation, stasis, party time, if the story is in the lower urinary tract, then we do a Foley's urethral catheterization or suprapubic cystostomy. If the story is in the upper urinary tract, then we do a endourinary stenting or a percutaneous nephrostomy. the stent which we use in the ureter. Let us just take a look at the picture of that stent, beta. Yeah, this what you are seeing here, beta. Can you see? This is the double J stent. There's a coil which remains inside the bladder, and there's a coil which remains inside the kidney so that the stent cannot migrate. This is the picture showing the stent which looks like this. Okay, fine. So we can just make a note here. For emergency urinary obstructions, upper urinary tract, we have got two options: endo-urinary stenting this is a DJ, double J stent. Acha beta, DJ, duodenal atresia. What was the treatment of choice for duodenal atresia? Duodenostomy, TD करते थे, है ना. Alternative treatment was DJ. Same for annular pancreas. We were doing DD for annular pancreas, and alternative treatment was DJ. Another option, what we can do is PCN. This is percutaneous nephrostomy. Percutaneous nephrostomy. While if we talk about lower urinary tract, obstruction, then first option what we have is Foley's urethral catheterization. Or if we are not able to pass a Foley's urethral catheter, beta, फिर और क्या कर सकते हैं? What else we can do? SPC. SPC क्या हुआ? Suprapubic cystostomy. Suprapubic cystostomy. Suprapubic cystostomy. Right. So this is all about the urinary stone story. Right, beta? I hope we are able to understand. If we just take a quick revision. Like in the urinary stones, what we talked about, the commonest kidney stone is calcium oxalate, that to dihydrate. Bladder stone most common. In boys, it is triple phosphate. In adults, it is uric acid. There are different type of urinary stones which can be seen. What can be the different reasons? Most common is idiopathic hypercalciuria. However, idiopathic hyperoxaluria, idiopathic hyperuricosuria, prolonged immobilization, urinary tract infection where cranberry juice used to prevent UTI, deficiency of vitamin A, hyperparathyroidism, milk alkali syndrome. So many reasons. Apart from this, we saw that there can be calcium oxalate stones, which can be monohydrate, dihydrate, monohydrate second hardest, dihydrate most common. They occur in normal urine pH, and they are spiculated, so there are more chances of causing hematuria. Triple phosphate stones, calcium, ammonium, magnesium phosphate, they occur in alkaline urine, especially when the patient is having UTI, especially with urea splitting organisms like Proteus. These triple phosphate stones are most radiopaque stones. They are called as true-white stones. They usually remain silent and they can take the shape of pelvic alluvial system when we call them as staghorn stones. The uric acid stones are smooth, round, or oval in shape. They occur in hyperuricosuric patients, acidic urine. They are radiolucent, not visible on X-ray. Various stones not visible on X-ray. PG में जाएंगे, लक्स से नहाएंगे. Lux, lysine, uric acid, and xanthine. P. parotid, G. gallbladder. Cystine stones. They are the hardest stones. They occur in cystinuria patients. They are difficult to be broken by shock waves. Then how these urinary stones can present to us? Most common presentation is pain, but earliest symptom what the patient would have experienced earlier would have been frequency of micturition. Sometimes hematuria can occur, sometimes interruption of urinary stream can occur if there is a large bladder stone. Now pain depends on the site of the stone. If the stone is in the kidney, fixed lumbar pain. Upper ureter, lumbar pain radiate to perineum in females and testis in males. Pelvic brim stone, lumbar pain radiate to inner thigh. Middle ureter stone, lumbar pain radiate to iliac fossa. Intramural ureteric stone or lower ureteric stone, strangury, painful desire to pass urine with passage of few drops of urine or blood. Stone inside the bladder, suprapubic pain. Stone slipping at the bladder neck or in the urethra, suprapubic pain referred to the tip of penis. When the patient comes to us in emergency with severe pain, the first medicine what we give is diclofenac. We can also give tamsulosin, which relaxes the muscles of the ureter and relieves the spasm. Once the patient is stabilized, we take a X-ray of kidney, ureter, and bladder. 80-90% of urinary stones can be seen on X-ray. If not, we can do an ultrasound of kidney, ureter, and bladder, but the investigation of choice will be non-contrast CT scan. We should not use contrast because the density of the contrast and the stone is same. In the treatment, we want to get rid of these stones. Less than 5 mm stones will pass spontaneously in urine, so just encourage plenty of fluids. More than 5 mm stones in the urinary tract, the treatment of choice would be ESWL. Especially for kidney, upper and middle ureter, we are doing ESWL. However, if there is more than 1.5 cm stone in the kidney and the upper ureter, we prefer doing a PCNL, that is percutaneous nephrolithotomy. If the stone is in the lower ureter, then we do ureteroscopic retrieval by Dormia basket. If the stone is in the bladder, we do a cystoscopy and we break the stone inside the bladder, litholapexy. PCNL, complication, bleeding. Sometimes, since we are using the 12th rib approach in PCNL, there can be injury to pleura, which can lead to hydrothorax and hemothorax. There can be injury to the colon or the spleen, but not to the lungs. Extracorporeal shockwave lithotripsy. Shockwaves are fired directly onto the stone, which break the stone into small fragments which align themselves in the ureter like a Steenstrasse phenomena, and then they pass spontaneously in urine. However, commonest complication of ESWL is bleeding. Shockwaves should be avoided if the stone is more than 1.5 cm in size, pregnancy, bleeding disorders, distal obstruction, and cystine stones. In emergency situations, if there is a traffic jam in the upper urinary tract, we can do endourinary DJ stenting or PCN, percutaneous nephrostomy. If there is traffic jam in the lower urinary tract, we should go ahead with Foley's urethral catheterization first. If not possible, then suprapubic cystostomy. Right, beta? Okay, so I hope we have got the clear idea about it. And another story in the flank area is urinary tuberculosis. Normally, when we talk about UTIs, we saw that video that how the perineal organisms ascend upwards into the urinary tract and cause UTI. That means, moral of the story, majority of UTIs, they are ascending infections. Majority जो UTI होते हैं, उसमें बैक्टीरिया कहाँ से आता है? नीचे रेक्टम से आता है, पेरिनियम से आता है, तो पेशेंट को UTI होता है, majority of UTIs. But TB of the urinary tract is not an ascending infection. Actually, it is a hematogenous infection. The primary focus of TB may be in the lungs. And from the lungs, the mycobacteria would have traveled into the blood, and through blood, the mycobacteria comes into the kidney. Now, beta G, how the story in the kidney occurs, if suppose I say that this is the renal parenchyma and here this is the calyceal system, and this is the ureter going down, and here this is the urinary bladder, and this is the urethra. Right. Majority of infections we know. Majority of infections, they are coming from the rectum and they are causing UTI. So these are called as ascending infections. Right. But TB is not an ascending infection. In TB, the primary focus may be in the lungs. Maybe there is TB in the lungs. And from there, this mycobacteria is probably coming into the blood. And through blood, these mycobacteria come into the kidney. Now, when these mycobacteria are coming towards the kidney, the first place where they settle is the renal papilla. Renal papilla is that part of minor calyx where the nephrons are opening. Suppose I say there are millions of nephrons here, and these nephrons, they have got the collecting ducts. So that point where the collecting duct opens into the minor calyx, that point where the collecting duct of the nephron opens at the minor calyx, that is called as renal papilla. And these mycobacteria, beta, they first settle at the renal papilla. And mycobacteria is known to cause caseation necrosis. So these mycobacteria, they will start causing necrosis of the renal papilla, and because of that there will be an ulcer developing at the renal papilla. This is the earliest change what we see in renal TB. There may be erosion of the minor calyces by this bacteria. Earliest change in kidney TB is erosion of the minor calyces. First papillary ulcer develop, and then there is erosion of the minor calyces, which we call as moth-eaten calyces. ऐसा लगता है कोई कीड़ा इन calyces को खा गया है. So gradually what will happen? The mycobacteria is causing erosion of these calyces, indistinct calyces, moth-eaten calyces. Then this mycobacteria will start partying in this area. Right? Caseation necrosis. This may spread into the kidney as well, and if it spreads into the kidney, there may be a caseation necrosis of the kidney. Caseation is something like cheese, beta, and cheese is just like a putty, cheesy white caseation, right? So maybe something like this, or rather I should say something like this. This might be seen in renal TB. So the entire kidney may be converted into a putty kidney type of thing. Putty is a substance which is used to fill the crevices in the walls before the wall is painted. This is the appearance what I would like to show you here. See, can you appreciate what has happened inside? This is the caseation necrosis. This is putty kidney. Putty is a substance which is used to fill the crevices in the walls before the wall is painted. जब भी पुताई करते हैं ना बेटा, तो दीवारों में जो गड्ढे होते हैं उनको भरने के लिए हम पुट्टी का इस्तेमाल करते हैं. This caseation necrosis of the kidney also looks like the same putty. And if you keep that putty under the sun in hot climate, putty becomes hard. So this putty kidney can also become hard, and that is called as cement kidney. So the different stages of kidney TB, the story started with a papillary ulcer, moth-eaten calyces, putty kidney, cement kidney. what happens to the cement? What happens to the Indian cement? It does not stay on the walls, it keeps on falling down ना. हमारे हिंदुस्तानी सीमेंट का क्या होता है? ये दीवारों पे टिकता नहीं जाता, गिरता रहता, झड़ता रहता है. The same thing will happen inside the kidney. This kidney will start breaking, and a stage may come when the entire kidney disappears. Autonephrectomy can occur. So there can be different stages of kidney tuberculosis, starting with the papillary ulcer, moth-eaten calluses, putty kidney, cement kidney, and autonephrectomy. If we talk about the bladder TB, the mycobacteria, they descend from the kidney downwards. Now suppose we were just talking about this story where the first story was papillary ulcer, then moth-eaten calluses, then the putty kidney, cement kidney, and then the kidney broke, autonephrectomy. Apart from this mycobacteria can also involve the urinary bladder. Generally, ureteric TB is rare. Why? Because the mycobacteria will be falling down with the flow of urine. So there are less chance of these mycobacteria to get stuck at some place in the ureter. Urine is continuously coming down. So mycobacteria will also be continuously coming down. This ureter, suppose, is going like this here. So the mycobacteria are also coming here. The earliest change what we see inside the bladder is around the ureteric orifice. Earliest change in bladder TB is seen around the ureteric orifice, and many a times because of infection, fibrosis in this area, the ureteric opening is pulled inside and appears like a golf hole ureteric orifice. जैसे गोल्फ का होल होता है ना बेटा, वो ग्राउंड के लेवल से नीचे होता है. द गोल्फ होल इज बिलो द ग्राउंड लेवल. So if the ureteric orifice is pulled inside due to fibrosis in the bladder, then this looks to be pulled inside. The surface level you can consider here, but if it is pulled inside, it looks just like the golf hole. Eventually, what can happen in bladder TB, if the entire bladder gets infected by TB, then entire bladder may heal by fibrosis and the entire bladder may get shrunk. This narrow shrunken bladder or narrow contracted bladder, this is what we call as a thimble bladder. That is because when the entire bladder is getting involved and fibrosis occurs, the bladder gets contracted. That is thimble bladder. So let's take a look at the different stages of these urinary tuberculosis. The most important thing, beta, urinary TB is a hematogenous infection. In the bracket, it is not an ascending infection. Generally, UTIs are ascending infection, but TB of the urinary tract is not ascending. If we first focus on renal tuberculosis and then see the bladder tuberculosis, in renal TB, the story starts at the renal papilla. So we find an ulcer at the renal papilla. If the party continues, then the entire kidney will undergo caseation necrosis, and this will result in putty kidney, which will gradually transform into cement kidney, and this cement can jhad or cement can break, that is autonephrectomy. In bladder TB, first what we see is golf hole ureteric orifice, That means earliest change in bladder TB is seen near the ureteric orifice, and gradually when the entire bladder gets involved, the entire bladder becomes narrow contracted, and this is what we call as thimble bladder. Thimble bladder. Investigation of choice for urinary TB is a CECT. However, beta, the first investigation what we are doing is a urine examination. Whenever any patient comes to you and you suspect UTI, first what you do is a urine examination. Midstream, early morning, urine sample is taken. Why we say early morning urine sample is the best urine sample to diagnose urinary pathologies? Because overnight the bladder would have been full, and if there is any infection or something, the bacteria would have got whole night to enjoy and party. So maximum chances of extracting those organisms or finding those organisms will be in the first urine sample of the morning. So first urine sample of the morning is the best urine sample to identify any bacteria inside. We take a midstream sample, we do the examination. In urinary tuberculosis, Mycobacteria is an acid-fast bacilli, so we find acidic urine. There will be a lot of bacteria in urine. That means lot of pus cells in urine because Mycobacteria is full in the urinary tract. So there will be pyuria, acidic urine, pus cells in urine, pyuria. And when we culture this urine to find out who is the culprit, whether it is E. coli, Proteus, Klebsiella or something, then we should know beta, Mycobacteria does not grow on the culture medias for these organisms. Mycobacteria require a special LJ media, Lowenstein-Jensen media, and it takes 6 weeks time for the Mycobacteria to grow on LJ media. That means when the microbiologist is examining this urine sample and he's putting this urine on the different culture medias to identify the different microorganisms. If it is Mycobacteria, it will not grow on the culture media used for E. coli or for Proteus or for Klebsiella. And when the microbiologist is looking at those culture plates, even after 24 hours, 48 hours, he will not be seeing any bacterial colony growing in those culture medias. So he might give you the report that no growth seen even after 24 or 48 hours of incubation, the urine is sterile. This type of urine report in February 23, sterile, acidic, pyuria, should immediately make you suspect कि boss, this can be a case of TB. Pus cells are there in urine, but when we are culturing, there is no growth because Mycobacteria is not going to grow on these culture medias. It will take 6 weeks on LJ media, right? So this is important in urinary TB, sterile, acidic, pyuria. Sterile, acidic, pyuria. This will make us suspect, yes, this is a case of TB. Now, when we do CECT or we do a IVP, in kidney TB, early change what we see is moth-eaten calyces, which we can say as indistinct calyces. And in late stages, we see a pseudocalculi appearance. While in case of bladder TB, earliest changes Golf hole, ureteric orifice, and late stages we see a thimble bladder. And the treatment for TB, we all know it is a standard anti-tubercular therapy. By giving this anti-tubercular therapy, we would be able to treat the urinary tuberculosis. If we take a look at some of the images, Peter, that how the urinary TB can look like on contrast studies. See, this what you are seeing here, Beta. These are the erosion of minor calyces, what you can see. These are indistinct calyces. This is moth-eaten calyces. This is the earliest appearance what we see in renal tuberculosis. Right? Gradually what we can find here is, if you see here in this image, Beta, can you see this pseudocalculi appearance? This indicates putty kidney and cement kidney. Right? The other kidney is normal. Okay, so this is what is a pseudocalculi appearance. This is just a pictorial representation of how the ureteric orifice may be pulled inside the ureter. This is a Goldfold ureteric orifice seen in bladder tuberculosis. And this is a narrow contracted urinary bladder. Now herein, this shadow what you are seeing, Beta, this is the narrow contracted urinary bladder. This is what we call as thimble bladder, right? Okay. So these can be the different appearances. To find these images, Beta, just search the study material, what is there in your application, and you may be able to find some of the images out there as well. Right. So this is all about the story of lumbar region. Now, Beta, what we'll do, we have discussed in detail about the urinary stones and the urinary tuberculosis. We'll take a break here. And after the break, let's discuss about the appendix, inflammatory bowel diseases, and so on. Thank you very much for your patience, Peter. Hello. Right, beta. So we are back. And now, in this particular session, we'll be taking a look, a small communication beta. Today, we'll not be taking the lunch break up to 3 p.m. We'll be taking another break of 20-25 minutes after this 2 hours. And then we'll be taking a break somewhere around 3:10, 3:15 p.m. And then we'll be resuming again by 6:30, that is the scheduled time. However, if by chance we can make it a little early, say 5:30 or 6, I'll just be informing in the WhatsApp groups beta. So just have a look at the WhatsApp group at around 5 o'clock, so that if we are starting at 5:30, then you do not miss out. Though the scheduled timing as of now is 6:30, but if by chance I can make it a little early, if I get free early, we'll start by 5:30 or 6, depending on the situation beta. As of now, the message is till 3 o'clock. We are not taking a long break. We'll be taking a break of 20-25 minutes after 2 hours, and then we'll be resuming at 6:30, and we'll be going up to 8:30 or so, right? Chali beta. So I hope that you are done with the flank area, the urinary stones and the urinary tuberculosis area, and now we move towards the iliac fossa. Before we move, let me just have a quick recap if I missed out on something. Ragul, shock waves are not used in pelvic area. That means we don't use the shock waves in lower ureter and bladder, simply because there are pelvic organs and shock waves can cause damage to the pelvic organs. ATT beta is anti-tubercular therapy. We know the different medicines. Used for treating tuberculosis, like isoniazid, rifampicin, pyrazinamide, ethambutol, streptomycin. So all these are anti-tubercular drugs, and we use this ATT, which has got a definite regime, which the entire regime will be discussed with you in the classes where tuberculosis is taught in detail. Right. In bladder TB, we prefer using a cystogram HEMA. That is just to give you the different images seen in kidney TB and bladder TB on various contrast studies. However, we prefer doing a CECT nowadays. Right, beta. So we are done with the majority of the queries, I guess. Yeah, fine. Now let's take a look at the another important story, that is about the appendix. But before that, as we were talking, let's take a look quickly at the indexing part. In the indexing part of adult surgical problems, let us see. I hope we are not missing out on something and everything is under our control. So we have talked about the thoracic stories, the dysphagia stories, the surgical chest pain stories, the epigastric story, the gastritis peptic ulcer types, the right hypochondrial story, the gallstones, the pancreatitis, liver abscess, sigmoid volvulus, and here we have talked about urinary stones and tuberculosis. Now we are taking a look at the appendicitis, inflammatory bowel disease, and diverticulosis of colon. And then we'll move down to the lowermost part of the abdomen, and then we'll be talking about the groin area. Okay, right. So I hope the situation in these topics is nicely under our control. Regarding this appendix, we know that appendix is located in the right iliac fossa, and if we take a look at some of the anatomy related pictures for appendix, this what we are seeing are the different positions of appendix. Now in this, normally beta we know that appendix is lying close to the cecum. Majority of the appendix, they are located behind the cecum, that is retrocecal. The second commonest position is the pelvic position, where the appendix is going towards the pelvis. However, the appendix may be paracecal in location, that is on the side of the cecum. It may be beneath the cecum, subcecal. It may be subileal. It may be found behind the small intestine, that is postileal. It may be found in front of the small intestine, which we call as preileal. So these are different positions of appendix. The commonest being the retrocecal, and second commonest the pelvic. Least common being the postileal and the preileal positions. In the anatomy, we know there's a line which we can draw from the umbilicus, and this line would be going towards the anterior superior iliac spine, the junction of medial 2/3 and lateral 1/3. This is called as the McBurney's point, and this McBurney's point is a site for appendix. Majority of these appendicitis patients, they present with pain at this particular area. We can elicit tenderness at this particular area, and when we are doing operations for appendix, we make an incision at the McBurney's point, the McBurney's incision or the gridiron incision. Apart from this, beta, these are the images, the laparoscopic images of appendix. Herein, what you're seeing, this particular thing, what you are seeing is the cecum, beta. This whole story, what you're seeing is the cecum. Here is the base of the appendix. This is the point where appendix is attached to the cecum. So this is the base of the appendix. Then this tubular structure, what you are seeing, this is the appendix. So here would be the tip of the appendix. This what you are seeing, beta, this yellow story, this is the mesentery of the appendix, that is mesoappendix. And in this mesentery, the blood vessel supplying blood to appendix would be there. This what you are seeing is a normal appendix. But when the appendix gets inflamed, we all can understand signs of acute inflammation, rubor tumor, calla dolor. So you may find this appendix to be red hot, inflamed, edematous, like that. So this image is a normal appendix, while this image is a turgid appendix. It may not be seen as red hot in this particular picture, but at least you can see that the diameter of the appendix is more here, right? That is one of the important indications of appendicitis. Whenever the appendix is going to get inflamed, you can very well see what is happening to this particular patient here. Right? So this is how the appendix will get acutely inflamed, and the patient most often presents with a periumbilical pain which actually migrate towards the right iliac fossa. Yesterday we talked about the gallbladder, beta. We saw that whenever the mouth of the gallbladder was getting blocked by a large stone, then mucus used to get collected inside the gallbladder. Stasis of mucus, open invitation to the bacterial party, acute inflammation. The same concept we will apply with the appendix also, beta. Herein, this is the appendix what you are seeing. Now in this appendix, sometimes what can happen in constipated individuals, those who eat less fiber in diet, if they remain constipated, the fecal matter is going to stay here for a longer period. Though rectum and sigmoid are the major reservoirs, but we can understand that the colon would be having this fecal matter. So if the patient is constipated, the fecal matter will become hard, and there is a possibility that mouth of the appendix may get blocked by this fecal ball, or you can say the fecalith. Now just imagine, beta, if the mouth of the appendix is getting blocked by a fecal ball or a fecalith, that means hard fecal matter. What will happen to the lumen of appendix? You know that this appendix will be lined by mucosa, which is secreting mucus. So if there is a traffic jam here, the mucus is going to get collected in the appendix. So appendix will become dilated. This appendix will become somewhat like this, and mucus will get collected inside this appendix. This collection of mucus inside the appendix, stasis, this is called as mucocele of appendix. Stasis of mucus, open invitation for the bacterial party. So the bacterial party will start in the appendix, and this is going to cause acute inflammation of the appendix. So the appendix will become somewhat like this, and this is what we are saying as acute appendicitis. Now, how these patients actually present to us? Most often, the patients are actually having pain in the periumbilical region, which remains here for a few hours. Then it shifts from the periumbilical region towards the right iliac fossa. And this is what we call as shifting right iliac fossa pain, or the migratory right iliac fossa pain. Just imagine that if the appendix is grossly inflamed, acutely inflamed, the patient will have nausea, vomiting type of thing, maybe fever, but generally fever is not high grade in acute appendicitis, right? So this may be the presentation of the patient. Now, you as a doctor, when you're working in the hospital, this patient will come to you in emergency with classical pain in the right iliac fossa. When you take the history, he might tell you that actually the pain started from here. You ask the patient to use his index finger and tell us from where did the pain start. And he starts showing that pain started here and then it shifted here in the right iliac fossa. This demonstration of pain path by the patient's finger is called as pointing sign. You see the pulse, there would be mild tachycardia. Sometimes you may not even get that very high pulse rate. In acute appendicitis, generally the pulse rate is around 90 beats per minute. The temperature in acute appendicitis is usually below 100.4 degree Fahrenheit. When you do the clinical examination, you always start palpating from the non-pathological area, and you come to the pathological area in the end. Now, when you are palpating, and if you put pressure at the McBurney spot, patient winces in pain. This is called as tenderness. Pain on pressure is tenderness, right? Pain on pressing the McBurney's point or the right iliac fossa. This is McBurney's sign. Now, when you try to release the pressure, then also patient winces in pain. This is called as rebound tenderness. Pain on releasing the pressure is rebound tenderness. Tenderness is understandable. When you are trying to press any red hot organ, there will be pain. Like in gallbladder, when the gallbladder was red hot inflamed, and when you try to insinuate your four fingers beneath the right costal margin and you ask the patient to take a deep breath, patient suddenly catches her breath. That was Murphy's sign in acute cholecystitis. Why? Because that red hot gallbladder immediately touched your fingers. So same thing will happen here. If you press on the McBurney's point, you're pressing on that red hot appendix and patient winces in pain. This is tenderness or McBurney's sign. When you release the pressure, then also patient winces in pain. This is rebound tenderness. Ideally, if you're releasing the pressure from that red hot organ, patient should get relief in pain. But why the patient winces in pain on releasing the pressure? That is in those situations where the peritoneum, the parietal peritoneum, which is the innermost layer of the abdominal wall. Just imagine the right iliac fossa, beta. Just imagine this right iliac fossa. The appendix is getting inflamed. So the innermost layer of the abdominal wall, that is parietal peritoneum, if that also gets inflamed, right? Just imagine the innermost layer of the abdominal wall, parietal peritoneum, if that also becomes red hot. And now when you're releasing the pressure, that red hot peritoneum is coming back to its normal position, right? When you pressed it, you press the peritoneum as well as the appendix. So patient was having pain. When you're releasing the pressure on the appendix is released, but the parietal peritoneum is still moving. It is coming back to its normal position. And if that parietal peritoneum is red hot and that is moving, then the patient has got pain. This is what is rebound tenderness, or we can call this as Shotkin-Bloomberg sign. Shotkin-Bloomberg sign. Shotkin-Bloomberg sign. Sometimes in appendicitis, beta, we can elicit various other signs. For example, if you try to press in the left iliac fossa, if you just try to press in the left iliac fossa, sometimes when you're pressing in the left iliac fossa, the gas is shifting towards the right side, and if the appendix is inflamed, patient will feel pain in the right iliac fossa. Pressure in the left iliac fossa, pain in the right iliac fossa. This is Rovsing sign. Sometimes if the appendix is lying, suppose in the pelvic location on the obturator muscle, and now if you try to stretch the obturator muscle by asking the patient to flex the right hip, and then you internally rotate the right hip, you actually stretch the obturator muscle of the patient. And if a red hot appendix is lying on the obturator muscle, patient will have pain in the right iliac fossa. This is obturator sign. If suppose the appendix is lying in the retroperitoneal location here, and if you ask the patient to hyperextend the right hip, for example, herein, if you ask the patient to hyperextend the right hip, the psoas muscle will get stretched. And if the red hot appendix is lying on the psoas muscle, the patient will have pain in the right iliac fossa. This pain in the right iliac fossa on hyperextension of right hip is called as psoas sign. What we do in practice, we calculate a Alvarado score, that is a Mentrel score. And that Alvarado score comprises of Mentrels, M-A-N-T-R-E-L. This is Mentrels. Now herein, M is migratory right iliac fossa pain, A anorexia and nausea vomiting, T tenderness, R rebound tenderness, E elevated temperature, L leukocytosis, and S shift for neutrophils. There should be migratory right iliac fossa pain, anorexia, nausea vomiting, tenderness, rebound tenderness, elevated temperature, leukocytosis. This is acute inflammation. So neutrophils should increase, shift for neutrophils. Everything here is given 1 point except tenderness and leukocytosis. They are given as 2 points. If you sum up this entire score, the total score is 10. If this score is 5 or less than 5, then appendicitis is ruled out. But if the score is 7 or more than 7, then probability of acute appendicitis is high. So we can take the help of this Mentrel score, and clinically we can make the diagnosis of acute appendicitis. No investigation as such is required in acute appendicitis. If it is mild acute appendicitis, non-obstructive type of acute appendicitis, it can be treated nicely with antibiotics. But if it is an obstructive or a very severe type of appendicitis, then we have to do operation in emergency, and that is emergency appendicectomy. Suppose February 23, you make a clinical judgment of acute appendicitis and you tell the patient that, come, let's have a date inside the operation theater right now. You are planning to do an emergency appendicectomy in this patient. The patient may ask you, doctor, you have not done any investigation. How can you take me to the operation theater? Please show me before my operation whether I am having appendicitis or not. Now, if this type of situation is there, then you can do a CECT of the abdomen and show him, see, this is your inflamed appendix. That means best investigation to diagnose acute appendicitis would be a CECT. But that is something which is not routinely done. Okay? Sometimes there may be diagnostic dilemmas. Sometimes you might get confused. Patient is telling that there's pain in the right lower abdomen. But when I'm examining, I'm able to find the tenderness, but the rebound tenderness is missing. I'm not pretty sure. Suppose you are examining a 25-year-old girl, and when you take the menstrual history, she does not remember when she had her last periods. Now you start thinking, oh, whether it is appendicitis or it can be a ruptured ectopic pregnancy. Whenever these diagnostic confusions are there, then you can take the help of ultrasound just to rule out other differential diagnoses. So ultrasound abdomen is not done to diagnose acute appendicitis, but it is done to rule out other differential diagnoses. And when we do the ultrasound here, beta, we can find something like this. Herein, you can see there is a tubular structure. This is the tip of the appendix. There is a tubular aperistaltic non-compressible structure in the right iliac fossa with diameter more than 6 millimeter. That favors acute appendicitis, right? So, once the diagnosis is done, you have decided whether you are going to treat with antibiotics or you have to do a surgery. If you have to do surgery for acute appendicitis, it is appendicectomy, emergency appendicectomy. There are various incisions which can be used for appendicectomy, like there are muscle splitting incisions and muscle cutting incisions. Most commonly we use muscle splitting. Now, what is the difference between muscle splitting and muscle cutting? Just imagine that patient is lying in front of you on the operation table. February 23, you are wearing a surgeon's attire. You have got that scalpel in your hand. You make a cut at the McBurney's point, cut the skin, subcutaneous tissue, external oblique aponeurosis. Then comes the internal oblique muscle and the transversus abdominis muscle. You can take an artery forceps, put the blades of the artery forceps between the muscle fibers, open the blades of the artery forceps. You will split the muscle fibers. As soon as you split the muscle fibers, you will see the shiny peritoneum in front of you. You will just pinch that peritoneum and make a small cut in the peritoneum. As soon as you cut the peritoneum, you are inside the peritoneal cavity. Then, looking towards your assistant, you just try to move your finger inside the peritoneal cavity and you're trying to feel for the laddu inside, for that edematous appendix inside. If you are able to feel that laddu or that edematous appendix inside, you just deliver that edematous appendix out on the wound. That is how you can deliver the appendix out from the wound. Herein you can see nicely, this is the cecum, this what you're seeing is the appendix. And this what you're seeing, beta, this is the mesentery of the appendix, the mesoappendix, which is carrying the appendicular artery. So you just ligate this appendicular artery. You chop the mesentery of the appendix with a diathermy. so that you will be left only with this tubular appendix now. These instruments, what you're seeing here, these are non-traumatic Babcock's forceps. Once only a tubular structure is left, then the story is very simple. Like here what you're seeing, just a tubular appendix is seen here. You have removed the mesentery of the appendix. You just put a suture at the base of the appendix, put a clamp here, and then you have to just cut in between. So herein what you are seeing, you are just cutting here. As soon as you cut here, the appendix is removed, the appendix is out, handed over to the staff nurse of the operation theatre, and here you are left with the stump of the appendix. This is called as the appendicular stump. ये जो छोटा सा दिख रहा है ना यहाँ पे, with the small tiny thing what you're seeing, this is the stump of the appendix. Now it is said, beta, that there is a mucosa which you can see here. Though you have put a ligature at the base of the appendix, only a small mucosa is pouting here. People say that if you just put this back into the peritoneal cavity like this mucosa is a notorious mucosa. This mucosa of the appendicular stump can form relations with people around inside the peritoneal cavity, and there is a risk of fistula formation inside. So we should not leave the appendicular stump mucosa just like that in the peritoneal cavity. You have to destroy this mucosa, which you can do by putting some povidone iodine, or maybe you can use diathermy to destroy the stump mucosa, or we can use a purse string suture in the cecal wall. The ladies' purses which have got two strings, if you pull the two strings, the mouth of the bag closes. To open the mouth, you have to put your hand inside and then you open the bag, right? So we can put a purse string suture in the cecal wall. Now when you try to pull the two threads, you just ask the assistant to bury the stump within the cecum, and you just pull the two threads and tighten it so that the stump mucosa is buried within the cecal wall. Something like this. That is how the stump mucosa will be buried within the cecal wall, and now the chances of mucosa forming relations with people inside would be less. So that is how open appendicectomy is done. In laparoscopic appendicectomy, we generally make 3 ports, and with these ports, this is what we are seeing. This is the base of the appendix. Here is the cecum, and there up would be the tip of the appendix. What we are doing is we are trying to put a suture at the base of the appendix. Once the sutures are put, then we just chop the appendix, and this appendix is removed via the port. This is the stump mucosa. You can just diathermize, cauterize this stump mucosa, and that is how we can destroy the stump mucosa in laparoscopy. So this is a laparoscopic appendicectomy. Sometimes when we are making the incisions in females, the females are more worried about the cosmesis part. So instead of making a classical McBurney's incision, we can make it a little transverse, where we make incision along the Langer's lines, the skin creases which you have. It is said that if you are making any incision along the skin crease in the body, then the cosmetic outcome is good. So in females, we can use a cosmetic Lanz incision that is giving a little good scar as compared to the McBurney's incision. So since in McBurney's and Lenz, we have not cut the abdominal wall muscles, we have just split the muscles, we call them as muscle splitting. The advantage of not cutting the muscle, just splitting the muscle, is that the muscle power remains intact after the operation. That means the strength of this area is better. So the chances of herniation from this incision would be less. That is why muscle splitting incisions are commonly used. But many times we face some tough situations. Suppose you have cut the skin subcutaneous tissue, external oblique aponeurosis, you have split the internal oblique and transversus abdominis. You have pinched the peritoneum, made a cut on the peritoneum, and you are inside the peritoneal cavity and you're trying to feel for that edematous appendix in the right iliac fossa. But as we know that the commonest position of appendix is actually retrocecal. So when we are trying to feel for the appendix from the front, we may not find where is the appendix. The appendix would be lying here behind the cecum. In these cases, we want a wider incision. We want to relax the incision so that we can see inside, do the dissection and approach the appendix. For this, we have to cut the muscles. For this, we cut the internal oblique and transversus abdominis muscle, and that is what we call as muscle cutting incision. Agreed that the strength of this area after healing would be less and the chances of herniation will be more, but first we have to take out the appendix. So we have to cut the muscles to have a wider view inside. If we are making a muscle cutting incision like this, it is called as Rocky Davis. Sometimes we have to extend it medially, that is Fowler Ware. Sometimes we have to extend this laterally, that is Rutherford Morrison. So these are the various incisions which can be used for appendicectomy. Let's take a look. A question has been asked in the recent times that which of the following is not an incision for appendicectomy, and they gave the options of McBurney's incision, Land's incision, Rutherford Morrison incision, and a Cocker's incision. Cocker's incision, yesterday we were talking about, is a subcostal incision for cholecystectomy. Right, beta. We'll write about all that, don't worry. So, first we'll take a look. In the anatomy part, the most common position of appendix is retrocecal. The second most common position is pelvic. Least common, this LC beta, this is least common. So least common position of appendix is post-ileal. And second least common position is pre-ileal. We know nicely about the McBurney's point. This is the junction of medial 2/3 and lateral 1/3 of a line joining the umbilicus with anterior superior iliac spine. Junction of medial 2/3 and lateral 1/3 of a line joining the umbilicus with the anterior superior iliac spine. If you can just mark this here, what you're seeing here, the red dot, what you're seeing, this is the McBurney's point. Medial 2/3 and lateral 1/3 of a line joining the umbilicus with the anterior superior iliac spine. That is what is the McBurney's point. Now, most common cause of acute appendicitis. This is a fecalith obstruction. Fecalith obstruction. That means the story of acute appendicitis is related to constipation. Those individuals who take less fiber in diet, they have got high chances of constipation. Usually, acute appendicitis is a polymicrobial. Multiple bacteria are responsible for inflammation of this appendix. The common bacteria which are living in this particular area, they are the bacteroids and E. coli. Bacteroids and the E. coli. Parasitic infestations like pinworms. Other obstructive causes if there is a polyp inside the appendix or carcinoid tumor inside the appendix. If suppose this is the appendix here, then obviously we know there would be a mucosa, then the submucosa, muscle and serosa, right? So if there is any obstruction, maybe by fecalith here, or if there is a tumor growing inside the pancreas or a polyp growing in, if there is a tumor in the appendix or maybe a polyp in the appendix, that can also create a traffic jam situation, because of which whatever mucus is being produced, that mucus will get collected in the appendix, and this is going to cause distension of appendix with mucus. That is the mucocele of appendix. Stasis of mucus in this area, party time, bacterial party, and acute inflammation of the appendix. So that is going to be the story. Acute appendicitis is slightly more common in males than females. It is commonly seen in late teens, like 18 years, 19 years of age, or maybe early 20s, 20, 21, 22, 23 years of age. Earlier, there was a time when it was believed that appendicitis is more common in females, and then the people used to say that those girls who have a habit of taking a lot of chocolates, they have got more chances of acute appendicitis. Sugar, infection, deadly combination, right? So whenever we are consuming high amount of sugars, and suppose the environment is quite friendly for the growth of bacteria like rainy season, then you would have seen that the chances of boils, furuncles, फोड़े फुंसी होने के chances बारिश में ज़्यादा हो जाते हैं. जो लोग चीनी ज़्यादा खाते हैं, उनमें infection का chance ज़्यादा होता है. Now, if somebody is eating more amount of sugar, obviously there is insulin inside and that will be taking care. But if by chance you take excess sugars and insulin is not taking care, then the chances of infections would be high. Now, for acute appendicitis, there is a Mentrel score, what we take help of. M is migratory right iliac fossa pain. Please remember, beta, it is not just right iliac fossa pain. It has to be migratory. That means pain should have started in the periumbilical and then disappeared from periumbilical, migrated or shifted to the right iliac fossa. So the examiner may also write this as shifting right iliac fossa pain. A is for anorexia. N is for nausea, vomiting. When you examine these patients, T for tenderness, R for rebound tenderness, E for elevated temperature, when we do simple basic lab test, L for leukocytosis, that means total WBC count will increase. In U beta, in normal individuals, the WBC count ranges between 4,000 to 11,000 per cubic millimeter. In acute appendicitis, it rises from 11,000 to say 14,000 per cubic millimeter. And since it is an acute inflammation, it is not the lymphocytes which are going to be increased, but it is the neutrophils or the polymorphs which are going to be increased. So we find a shift for neutrophils. shift for neutrophils. Now this has also been asked in your FMG exam. Which cells are increased? Neutrophils, basophils, eosinophils, lymphocytes. So the answer is neutrophils. If we take a look, 1 point has been given to everything, but 2 points have been given for tenderness and leukocytosis. And if you calculate everything, then the total score is 10. If the score is 7 or more than 7, then there is high probability of acute appendicitis. But if the score is 5 or less than 5, then acute appendicitis is ruled out. Right. लिख लिया बेटा? चलिए, so simple to understand. Now, if we take a look at the clinical approach, what we are doing here is we ask the patient to demonstrate the pain path. Pain path demonstrated by the patient is pointing sign. Pulse rate is somewhere around 90 beats per minute. Temperature is less than 100.4 degree Fahrenheit usually. Tenderness at the McBurney's point. This is called as McBurney's sign. Rebound tenderness is due to elastic recoil of inflamed parietal peritoneum. This is called as Shotkin-Bloomberg sign. Shotkin-Bloomberg sign. Rebound tenderness in right iliac fossa in acute appendicitis. Shotkin-Bloomberg sign. When we are examining the right iliac fossa, because of inflamed appendix inside, the muscles in the abdominal wall of the right iliac fossa, they will resist external pressure. They'll become tight. So that is what we are calling as guarding and rigidity of the abdominal wall muscles. Various signs which we can elicit. McBurney's sign is pain in the right iliac fossa on pressing the right iliac fossa. Rovsing sign is pain in the right iliac fossa on pressing the left iliac fossa. Obturator sign is pain in the right iliac fossa on internal rotation of flexed right hip. And Swas sign is pain in the right iliac fossa on hyperextension of right hip. Hyperextension of right hip. Dunphy's is pain in the right iliac fossa on coughing. We just ask the patient to cough. Patient को खांसी करने को बोलते हैं. And if the patient has pain in the right iliac fossa, that is what is the Dunphy's sign. So these are few MCQ signs which may be of some relevance. Shotkin-Bloomberg was there, McBurney's, Rovsing, obturator, Swas, Dunphy's sign. Shotkin-Bloomberg. These are some signs in acute appendicitis. Generally, no investigation is required. Acute appendicitis is a clinical diagnosis. However, basic investigations when we are doing TLC, this is the total leukocyte count. Total leukocyte count. Normally it is 4 to 11,000, but in acute appendicitis we may find it between 11,000 to 14,000 per cubic millimeter. DLC. Now DLC is a differential leukocyte count, where we come to know about the different WBCs. So acute inflammation, it will be the neutrophils. Chronic inflammation, generally the lymphocytes. However, best investigation what we know for acute appendicitis would be CECT of the abdomen. Ultrasound abdomen is not done to diagnose acute appendicitis, but it is done to rule out other differential diagnosis. And if we find a blind ending tubular apericeltic structure in the right iliac fossa, which is having a diameter of more than 6 millimeter, then it favors acute appendicitis. This is the ultrasound showing that blind ending tubular apericeltic structure with a transverse diameter of more than 6 millimeter. This is what you're seeing here. And if the diameter here is more than 6 millimeter, then this favors acute appendicitis. Right. In the treatment for acute appendicitis, as we were discussing, for mild appendicitis, the treatment is non-operative, that is conservative, with antibiotics. For severe, we do operative treatment, that is emergency appendicectomy. If we are doing an appendicectomy, we have got the option of a muscle splitting. We have got the option of muscle cutting. We also have the option of laparoscopic appendicectomy. So muscle splitting is something what we are using most commonly. And most common incision what we are using is a McBurney's incision. McBurney's incision, which is centered over the McBurney's point. We also call this gridiron incision. The simple reason of calling it as gridiron, it is since it is muscle splitting, so the strength is more. The power of this incision is more, the chances of herniation are less. Gridiron is a term which has been taken from the grids of iron which are there at the harbors, जहाँ पे समुद्र में शिप खड़े होते हैं, समुद्री जहाज जहाँ पे खड़े होते हैं, जो उनका पार्किंग है जहाँ पे उनको रिपेयर किया जाता है. So those ships are actually repaired at those strong iron bars, and there is a special arrangement, something like this crisscross arrangement of those iron bars. So just because of the strength of the incision, we call it as gridiron incision. Another muscle splitting incision is a Lanz incision. This is cosmetic, so it is more commonly preferred in females. This is the transverse incision. Transverse incision. Then there is a muscle cutting incision. Muscle cutting are Rocky Davis, Fowler Ware. Fowler Ware is when we extend the Rocky Davis incision medially, and Rutherford Morrison. Now here beta, the names of these incisions are going to be relevant for us because we already have seen the question related to this. Rutherford-Morrison incision is when we are extending medially, extended laterally. Rutherford-Morrison is when we are extending the incision laterally. In laparoscopic appendicectomy, we are making 3 ports. In laparoscopic cholecystectomy, we are making 4 ports. Gallbladder निकालने के लिए 4 छेद करते हैं पेट में, appendix निकालने के लिए 3 छेद करते हैं पेट में, laparoscopy में. If I take you to these incisions once again, just have a look, beta. This, what you are seeing, this is the McBurney's incision. If we make a little transverse incision, and if it is a muscle cutting, then this is the Lanz incision. The other 3 are muscle cutting incisions. Like if this is the incision, this is a Rocky Davis incision. If we have to extend this incision medially, then it is Fowler wear. So this will be Fowler wear. If we have to extend this Rocky Davis incision laterally, then this is a Rutherford-Morrison. This is a Rutherford-Morrison. Or you can say this will be the Rutherford-Morrison incision, right? Okay, so this is how these different incisions are used for appendicectomy. Cocker's incision, beta. Cocker's incision is a subcostal incision which is used for cholecystectomy. So Cocker's incision, what you're seeing here, this is for cholecystectomy. It is not for appendicectomy. Most common complication of appendicectomy in the initial period, that means in the early period, there are chances of wound infection because we are dealing with good bacterial load. As we are moving far in the intestines, the bacterial load keeps on increasing. This wound infection is often seen after 4 to 5 days of operation. And late complication, what we can come across is post-operative adhesions, which can cause intestinal obstruction after years. When we are talking about duodenal atresia in pediatric surgery, there we discussed that most common cause of intestinal obstruction in a newborn baby is duodenal atresia. Overall commonest cause of intestinal obstruction are the post-op adhesions. So maybe after 5-10 years of appendicectomy, maybe there might be adhesions developing between the loops of intestine causing intestinal obstruction. So this is the whole story related to acute appendicitis. Very simple, same concept what we use in gallbladder. When there was a large stone blocking the mouth of the gallbladder, mucocele of gallbladder, acute cholecystitis. Same story here, fecolith obstructing the mouth of the appendix, mucocele of appendix, acute appendicitis. Commonly seen in males, slightly more common in males, I should say. Usually the age group is late teens and early 20s. Patient classically presents with migratory right iliac fossa pain. First, the pain starts in the periumbilical, then goes to the right iliac fossa. Anorexia, nausea, vomiting, and fever. Fever is not high grade generally. We ask the patient to demonstrate the pain path, pointing sign, pulse rate around 90, temperature less than 100.4. We can do the clinical examination. Tenderness in the right iliac fossa at McBurney's point is the McBurney's sign. Rebound tenderness due to inflamed parietal peritoneum recoil, that is Shotkin-Bloomberg. Localized guarding rigidity in the right iliac fossa. Other signs, Rovsing sign, that is pain in the right iliac fossa on pressing the left iliac fossa. Obturator sign, pain in the right iliac fossa on internal rotation of flexed right hip. Schwartz sign, pain in the right iliac fossa on hyperextension of right hip, Dunphy sign, pain in the right iliac fossa on cuffing. These are the various signs which can help us in finding out appendicitis. Acute appendicitis is a clinical diagnosis, the mental score or the Alvarado score. That is the score what we are using. M for migratory right iliac fossa pain, A anorexia, N nausea, vomiting, T tenderness, R rebound tenderness, E elevated temperature, L leukocytosis, S shift for neutrophils, 7 more than 7 high probability, 5 less than 5 rules out acute appendicitis. 2 points given to tenderness, 2 points given to leukocytosis, rest everything 1 point. Normally the total leukocyte count is 4 to 11,000, but in acute appendicitis it can rise from 11,000 to 14,000 per cubic millimeter. No investigation is generally required. However, best investigation would be CCT. Ultrasound is not done to diagnose appendicitis but to rule out other differential diagnosis. And if the diameter of appendix is more than 6 millimeter, then it favors acute appendicitis. In the treatment, if it is mild appendicitis, just conservative with antibiotics. If it is a severe obstructive type of appendicitis, we do emergency appendicectomy. Various incisions for appendicectomy: muscle splitting, muscle cutting, and laparoscopic. Muscle splitting, the McBurney's or the gridiron incision is the most commonly used incision for appendicectomy. Lanz incision is a cosmetic incision, transverse incision commonly used in females. In difficult appendicectomies, we have to cut the muscles, so the strength of the muscles become weak. Chances of hernia after operation will increase. We use a Rocky Davis incision if extended medially, Fowler Ware if extended laterally, that is the Rutherford Morrison incision. Cockers is something which is a subcostal incision used for cholecystectomy, open cholecystectomy. Early complication of appendicectomy is wound infection after 4 to 5 days of operation, and late complication after years is a post-op adhesions causing adhesive intestinal obstruction. This is the story of appendicitis. Now, sometimes what can happen if the appendix is getting grossly inflamed, bacterial party going on, sometimes this is a aggressive bacterial party and the antibiotics are not sufficient to control the infection. Party continues, abscess can form around the appendix. If there is an abscess around the appendix which is localized there, then we know पस को देख के सर्जन को कुछ होता है. पस पूरी बॉडी में कहीं भी हो हमें निकालना होता है. अगर पस किसी एक हिस्से में लोकलाइज्ड है और बॉडी के अंदर है तो पस को ऐसे निकालना है कि पस फैले ना. Whenever we are treating a localized abscess inside the body, agreed that we have to drain the pus, but we should not spill the pus inside. Otherwise, we'll spill the bacteria all over the place. That can lead to septicemia and death of the patient. So for these localized pus collections, the best thing is we make an incision on the skin. Under ultrasound or CT guidance, we put a catheter into the abscess cavity and drain that pus outside the body through that catheter. For gallbladder empymas, tube cholecystostomy. For pancreatic abscess, percutaneous drainage under ultrasound or CT guidance. For appendicular abscess, we call it as MCQ, commonly asked. Extraperitoneal drainage. So the concept is same, beta. What we are doing here, we are simply doing a ultrasound guided percutaneous drainage, and here the name what we are giving to this is extraperitoneal drainage. Extraperitoneal drainage. If we talk about appendicular masses, sometimes we come across situations. Suppose the patient is living in some remote areas, some remote village, and he develops acute appendicitis. He goes to the local doctor, he tells about his story, and the local doctor gives him some analgesics. The patient may get some relief, but if it is acute appendicitis, we can just imagine the situation going on inside his abdomen. As soon as the appendix got inflamed, the policeman of the abdomen omentum would be going towards the inflamed appendix and would be trying to envelop or seal the inflamed appendix from rest of the peritoneal cavity so that whatever bacterial party is taking place, that becomes localized and that does not spread to the general peritoneal cavity. During this process of omental adhesions around the appendix, sometimes it takes the help of neighboring people like the small intestine or the large intestine. So the small intestine, that means the terminal ileum or the cecum, may also get adhered along with the omentum to the appendix. And this can form a mass around the appendix in 3 days, 4 days, 5 days time. Now, when the patient develops this appendicular mass and goes to the doctor, the local doctor, the doctor gets confused. Oh my God, this analgesic has created this mass. And the doctor starts thinking, oh my God, what have I done? I don't know what is the problem. And then the local doctor will send this patient to the city, to some city area where a good doctor is there. Now you are the good doctor. February 23, when appendicular mass type of patients come to you in your practice, there is a mass in the right iliac fossa. You do the clinical examinations and everything, and suppose you come to know that yes, this is a mass. Should we do appendicectomy at this stage or not? The answer is no. Simple reason. If you try to do appendicectomy in masses, then you will have to separate the omentum, you will have to separate the small intestine and the large intestine, which might cause injury to the small or large intestine. You might be able to do appendicectomy, but not at the cost of injuring small or large intestine. As we were discussing in gallbladder surgeries, in acute cholecystitis, we were admitting the patient, giving the IV antibiotics. We were trying to settle the infection, which usually settles in 5 to 7 days time. Then we used to discharge those patients and call them back again after 3 to 6 weeks and then do a cholecystectomy, interval cholecystectomy, because maybe within 3 to 6 weeks time, whatever adhesions have developed, they may disappear on their own. So the same approach is what we are using here in appendix also. We admit this appendicular mass patient in the hospital, give IV fluids, IV antibiotics. That is a conservative treatment, non-operative treatment. Generally, the infection settles in 5 to 7 days. We discharge the patient to the home, call these patients again to the hospital when there is no infection, when there are no adhesions, and then we do a appendicectomy. That is what we call as interval appendicectomy. So interval appendicectomy is not done in emergency. It becomes an elective operation. That is why it is classified as clean contaminated. Right? Okay. So for appendicular mass beta, we do a conservative treatment, and there is a specific name given to this non-operative or conservative treatment, and that is Ochsner-Sharon regime. Ochsner-Sharon regime. In this, we are giving IV fluids and IV antibiotics for 5 to 7 days. Infection settles and we advise on discharge to come back to the hospital after 3 to 6 weeks, and then we are doing a interval appendicectomy. Right, beta? So this is how we are dealing with these appendicular masses. This is again a hot MCQ for 17th of December. This is the whole story about appendix. And now let's take a look at some inflammatory bowel diseases. Inflammatory bowel diseases, the Crohn's disease and ulcerative colitis. So what we'll do is, we'll take a look at the videos to understand about this Crohn's and ulcerative first. With those videos, we'll get good idea that what actually is Crohn's and what is ulcerative. Generally, these Crohn's and ulcerative colitis, They are commonly seen in Western countries. They are commonly seen in rich people, more common in whites. They are autoimmune probably. There is some relation of antibodies. Some antibodies form against some mucosal antigens, and then these antibodies try to destroy the mucosa there. So let's have a look. Generally, the age group is around 20 to 30 years of age or 20 to 40 years of age. Let's see those videos.
Crohn's disease is one of the two major forms of inflammatory bowel disease. Inflammation caused by Crohn's disease may affect any parts of the gastrointestinal tract, but it most commonly involves the end of the small bowel, the ileum, and the beginning of the colon. The inflammation is not continuous. Inflamed segments are usually interrupted by normal healthy tissues. Most people experience recurrent flares when the disease is active, followed by symptom-free periods of remission. Symptoms may differ depending on the parts of the digestive tract that are affected. Most common signs include diarrhea, abdominal pain and tenderness, loss of appetite, weight loss, fatigue, and fever. Blood and stool occurs when the colon is involved. Nausea and vomiting are usually the signs that the stomach or the first part of the small intestine is affected. About 1/3 of patients present with perianal disease, including abscess, fistulas, and ulcers. The disease also often manifests outside the intestine, especially in the joints, skin, and eyes. Inflammation in Crohn's disease extends to the entire thickness of the intestinal wall. Deep lesions in the mucosa often alternate with areas of mucosal swelling, creating a characteristic cobblestone appearance. Extensive inflammation may cause thickening of the bowel wall and hypertrophy of the mesenteric fat that wraps around the intestine. Intestinal wall thickening, together with scar formation, may block the flow of digestive content, leading to bowel obstruction. Ulcers can extend through the bowel wall and form tunnels, called fistulas, which may connect to other loops of the intestine, to abdominal organs, muscles, and even skin. A fistula may become infected and form abscesses, which can be life-threatening if not treated. In the long term, Crohn's disease may increase risks for colon cancers. The disease has a major peak of onset between the age of 20 and 30, and a smaller peak later in life. White individuals, people with family history, and smokers
जी
are
सर
at higher risks. The exact mechanism of
जी सर
Crohn's disease is not fully understood, but it likely involves
नहीं
both genetic and environmental factors. Multiple genes are identified, most of which act in the immune system,
4 बजे
or
मिलना है
in
ना सर
maintaining the gastrointestinal epithelial barrier.
हाँ
This barrier separates the gut content from the underlying immune system, preventing the body from reacting to dietary antigens and resident bacteria of the gut. A crack in the barrier may increase the chance that the immune system overreacts to non-pathogenic antigens from the gut content. Involvement of environmental factors is evidenced by higher disease incidence in developed countries, especially urban areas. Diagnosis is made based on a combination of tests and imaging procedures. Treatments start with dietary management to maintain good nutrition but avoid foods that may exacerbate symptoms. Some patients may benefit from nutrition therapy, a special diet given via a feeding tube or injected into a vein. The therapy provides nutrition while allowing the bowel to rest, reducing inflammation. A number of medications can be prescribed depending on disease severity and the patient's response to different drugs. These may include antidiarrheals, anti-inflammatories, antibiotics, corticosteroids, immunomodulators, and biologics. Abscesses and fistulas are drained and treated with antibiotics. Nearly half of patients require at least one surgery to manage recurrent intestinal obstructions or complicated fistulas or abscesses. Surgical removal of the diseased parts of the bowel may improve symptoms temporarily, but is not a cure because the disease is likely to recur, usually near the reconnected tissue.
Right, beta. So this was just a glimpse about the Crohn's disease. Now let's take a look at the ulcerative colitis as well.
Ulcerative colitis, UC, is one of the two major forms of inflammatory bowel disease. In UC, the inner lining of the large intestine is inflamed, causing open sores or ulcers. UC usually affects only the mucosa and submucosa layers of the intestinal wall. The condition evolves in the form of recurrent flares when new lesions form, followed by symptom-free periods of remission when these lesions heal. Typical symptoms include abdominal pain and persistent diarrhea, often with mucus and/or blood. Some patients may experience fecal urgency, fecal incontinence, or tenesmus, the inability to move bowels in spite of the urge. The disease also often manifests outside the intestine as a result of inflammation of joints, skin, and eyes. Severe cases can present with systemic symptoms, such as weight loss, nausea, vomiting, fatigue, and fever. UC usually starts from the lower end of the large intestine and may remain limited to that location, or it can spread upward and affect more of the colon, sometimes the entire colon. The disease is mildest when it is confined to the lower part of the bowel, in which case the main symptom is blood and mucus in stools, but the stools can be of normal consistency. Once the disease progresses to the upper colon, stools become more watery, sometimes consist entirely of blood and mucus. The patient may have multiple bowel movements per day, often with severe cramps and tenesmus. In the long term, UC may increase risks for colon cancers, but the most dangerous complication to watch out for is toxic colitis, or fulminant colitis, a life-threatening condition characterized by sudden violent diarrhea, high fever, abdominal pain, and signs of peritonitis. Toxic colitis occurs when inflammation extends into the smooth muscle layer of the intestinal wall, paralyzing the colon muscle. This may lead to colon dilatation and sometimes perforation. UC has two incidence peaks, one major peak in teens and young adults, and a smaller peak after the age of 50. Some races are more susceptible than others. Family history of the disease is also a risk factor. Ulcerative colitis is a chronic inflammatory disease where the ongoing immune response destroys the body's own tissues. It is associated with abnormally high levels of T helper cell response, specifically helper T cell type 2, Th2. The exact mechanism is not fully understood, but it likely involves both genetic and environmental factors. Multiple genes are identified, most of which act in the immune system or in maintaining the gastrointestinal epithelial barrier. A mutation in any of these genes may weaken the body's ability to regulate the extent of immune responses or to differentiate between self and non-self. An appropriate inflammatory response against a pathogen may get out of control and become chronic, or the body may mount an inappropriate response against its own antigens. Involvement of environmental factors is evidenced by higher rates of UC in developed countries, especially urban areas. Interestingly, smoking seems to have a protective effect. Diagnosis is mostly based on symptoms, but tests are done to exclude other causes. Stool tests to exclude infections, colonoscopy to rule out cancers. Treatments include dietary management to maintain good nutrition, but avoid foods that may cause discomfort. Diarrhea medications to relieve symptoms, except in case of severe attacks. Mild to moderate patients are prescribed topical or oral 5-aminosalicylic acid, depending on the affected locations. Extensive UC is treated with corticosteroids, immunomodulators, and biologics. Severe cases are hospitalized and managed with intravenous corticosteroids. Patients are observed closely for development of toxic colitis. Toxic colitis is treated with high-dose intravenous corticosteroids and antibiotics, and may require emergency surgery. Some patients with extensive disease may ultimately need surgery to remove the affected part of the colon. Surgery essentially cures the disease.
Now let us see the comparison.
Ulcerative colitis and Crohn's disease are the two major forms of inflammatory bowel disease. Both conditions are characterized by chronic inflammation of the gastrointestinal tract, or GI tract. Ulcerative colitis is limited only to the large intestine. It usually starts from the rectum and may remain confined to that location, or it can spread upward in a continuous fashion, affecting parts or all of the colon. Crohn's disease, on the other hand, can occur anywhere along the GI tract, but it usually involves the small intestine. Most commonly affected are the end of the small bowel, the ileum, and the beginning of the colon. Crohn's disease is not continuous. Inflamed segments are usually interrupted by normal, healthy tissues. The rectum is always affected in ulcerative colitis, but is usually spared in Crohn's disease. Ulcerative colitis only involves the inner lining of the intestinal wall, while Crohn's disease extends to its entire thickness. In imaging studies, the mucosa in Crohn's disease has a patchy appearance, with alternating regions of diseased and normal tissues. The bowel wall is affected asymmetrically. In ulcerative colitis, mucosal inflammation is diffuse and uniform. The bowel wall is affected symmetrically. Thickening of the intestinal wall, bowel obstructions, and fistulas are unique to Crohn's disease. Both conditions result from an inappropriate response of the immune system, but their mechanisms are likely different. Ulcerative colitis is associated with abnormally high levels of helper T cell type 2, while Crohn's disease has more type 1 activities. Age of onset and risk factors are similar for both conditions, with a notable exception of smoking, which exacerbates Crohn's disease but has a protective effect on ulcerative colitis. The two disorders share many common symptoms, such as diarrhea, abdominal pain, and extraintestinal manifestations. However, Crohn's disease symptoms can be more variable, depending on the affected locations, and often include anal fistulas and abscesses. Intestinal bleeding is much more common in ulcerative colitis, while malnutrition and weight loss is more common in Crohn's disease. When Crohn's disease involves only the colon, the symptoms can be indistinguishable from ulcerative colitis. Fortunately, because treatment is similar, no distinction is necessary unless surgery is considered. This is because surgical removal of the diseased colon is curative for ulcerative colitis, but only provides temporary relief for Crohn's disease.
Wonderful, beta. So I think these videos are definitely going to give us an idea that what actually happens in these inflammatory bowel diseases, the Crohn's and ulcerative colitis. If we just try to summarize what we learned in these videos, Crohn's both are diseases where the exact cause is not known, but probably it is thought to be some autoimmune issue. Maybe there is a hyperimmune response, T helper type 1 in Crohn's and T helper type 2 in ulcerative colitis. Generally, they are common in the younger age groups around 20 years of age or maybe 20 to 30. There is a second peak around 60 years of age in both. They both are common in white people, Western people, rich people, right? Now, smoking is a risk factor for Crohn's, but nobody knows it is protective in ulcerative colitis. Basically, the difference here is Crohn's disease can affect any part of GIT. Crohn's disease can affect any part of GIT. That means right from mouth to the anus. However, the commonest site in Crohn's is the terminal ileum and then the cecum area. But it can even involve the stomach duodenum area. It can even involve the colon area. Important to notice, in Crohn's there are skip lesions. That means if there is a disease here, then there would be a normal segment and again there will be a disease segment. right? If we look at the ulcerative colitis, then ulcerative colitis always starts in the rectum. The name itself implies colitis. So it is the large intestine story. Always affects the rectum and then it spreads proximally in continuity. If it is involving only the rectum, proctitis. If it involves the sigmoid, proctosigmoiditis. Then if it involves the colon, proctosigmoidocolitis. Like this is proctosigmoidocolitis. If it involves the entire colon, this is pancolitis or universal colitis. It can even spread to the small intestine. That is called as backwash ileitis. Backwash ileitis. Okay. Ulcerative colitis is always starting in the rectum. But Crohn's disease is something where rectum is usually spared. Rectum is usually not involved. Another important differentiation in the two is this. Now, ulcerative colitis involves only the mucosa and the submucosa, but Crohn's involves all the layers. If it is involving only the mucosa and submucosa, we actually find multiple minute tiny ulcers in ulcerative colitis, right? And here in Crohn's disease, what we see, there are swellings and depressions. There are skip areas in between. So we find this cobblestoning. Cobblestone is something like जैसे सपेरे की बीन होती है. The snake catches, they carry an instrument, right? So that is what is a cobblestone. So the mucosal appearance in Crohn's disease is somewhat like that instrument, cobblestone appearance. We see serpentine ulcers, deep ulcers in Crohn's disease. But we just see collar button ulcers in ulcerative colitis, right? Crohn's disease, we find non-caseating granulomas. Ulcerative colitis, we find non-specific inflammation of the mucosa and superficial submucosa. Now, how these patients actually present to us? We have already discussed about their age of presentation and everything. Like they are more common in this particular age group, second peak at around 60 years of age. They are more common in white people, right? So people who live in urban areas, rich people, these Crohn's ulcerative colitis is more common there. And we also saw that smoking is a risk factor in Crohn's, but it is protective in ulcerative colitis, right? Okay, now how these patients are going to present to us? Very simple to understand, beta. If there is a disease which is involving the colon, sorry, then the patient presents with diarrhea. Usually in ulcerative colitis, the patient presents with blood and mucus in stool. So mucus diarrhea or a bloody diarrhea. Depending on the severity of disease, beta, if it is only mild, we can understand the amount of motions he is passing per day or the frequency of stools he is passing per day would be less. So if the person is passing less than 4 stools in a day, mild, less than 6 stools in a day, moderate, more than 6 stools in a day, severe, more than 10 stools in a day, maybe fulminant type of ulcerative colitis. So it depends on the disease severity, the frequency of motions will also increase accordingly. While Crohn's disease can present with diarrhea and abdominal cramps, since Crohn's disease is a transmural disease, that means all layers are getting involved. So the chances of traffic jam are more in Crohn's disease. So these patients can even present with intestinal obstruction. However, it depends on which part of the GIT is involved in Crohn's. Like if there is a stomach duodenum involvement, the patient will have more nausea and vomiting. If the patient has got this intestine involved, the patient will have more abdominal cramps. If the colon is involved, then the patient will have diarrhea, right? So these constipation, diarrhea, anything can happen in Crohn's disease patients. Apart from this, in Crohn's disease, there are very high chances of perianal disease also. Now, in this perianal disease, there are fistulas which can be seen, there are abscesses which can be seen. In Crohn's disease and ulcerative both, we can find the extraintestinal manifestations. Because we are thinking that it is autoimmune, that means there is some role of antibodies. So it is not only the antibodies which are targeting the GI mucosa, but maybe they are targeting other areas also, like joints, joint involvement, maybe sacroiliitis, ankylosing spondylitis type of things are seen. Maybe there is involvement of the skin like erythema marginatum, pyoderma gangrenosum type of things, erythema nodosum, pyoderma gangrenosum can be seen. Eyes, there is uveitis, scleritis type of story. Bile duct, there is primary sclerosing cholangitis type of story. Cancers can even occur in Crohn's and ulcerative, though they are more common in ulcerative colitis as compared to Crohn's. Now, to diagnose these conditions, for Crohn's, which is affecting the terminal ileum, we do a CECT. And for ulcerative colitis, which is affecting the colon, we do a colonoscopy, right? We know when we have to do endoscopy, beta, we can pass the upper GI endoscope through the mouth into the esophagus, stomach and duodenum, but not into the jejunum and ileum. When we have to do a lower GI endoscopy, we can pass the endoscope through the anus into the rectum, sigmoid, descending, transverse, ascending and cecum, but not into the ileum and jejunum. So for jejunum and ileum area, we prefer doing a CECT. And for colon, we prefer doing a colonoscopy. Right. Apart from this, if we are doing a contrast study, like for terminal ileum, the contrast study, what we do is a barium meal follow through. So what we can find in these Crohn's disease, if we just try to focus here, suppose I say there is a transmural disease affecting the terminal ileum, and this is going to cause narrowing of the lumen. So when you are doing a barium meal follow through, you are giving the contrast from here, the contrast is traveling here, the contrast is going into the duodenum and then it is coming into the jejunum and ileum. Now in this particular area, if there is a narrowing here, this part of the ileum will be filled nicely by the contrast. But then there will be just a line of contrast which is passing through the narrow area. This line is called as a string, dhaga, string sign of Cantor. Even in tuberculosis of the intestine, when the terminal ileum is getting affected and suppose the terminal ileal wall is getting fibrosed, the lumen gets narrow, and then also we find a string sign here, right? So this is what we can find in these Crohn's and ulcerative on imaging studies. In the treatment beta, because these diseases are thought to be autoimmune, so the mainstay of treatment for these are steroids. In colonic disease, we use 5-aminosalicylates. Whenever we find inflammations, we can use these 5-aminosalicylates. But the mainstay of treatment for both Crohn's and ulcerative are these steroids. Sometimes there are possibilities when the disease becomes steroid dependent. As soon as the patient leaves the steroids, the symptoms recur again. Or if suppose the steroids are not able to treat, the patient is not getting any relief, or if there are any complications of this Crohn's and ulcerative colitis, like we talked about some toxic colitis, sometimes there may be massive bleeding going on, sometimes there may be perforations in the colon. So we have to do surgical intervention there. Sometimes when the risk of cancer is high, sometimes when there are extraintestinal manifestations, then we have to think about surgery. Now, surgery in Crohn's disease is really difficult because as you can see on the screen, and you are the surgeon, generally what the surgeons are supposed to do, they have to just chop the disease segment and anastomose the remaining segment. Herein we are facing a challenge. If we remove the disease segment and try to join the normal segment, again there is a disease segment coming up. So again we'll have to do chopping and do the union. So multiple choppings would be required, and that would not give good results in the anastomosis. So surgery is something which is actually neither curative and also difficult in Crohn's disease. But in ulcerative colitis, yes, if the disease is quite severe, for example, if we talk about this story, then the patient may not be getting relief with the steroids and all that stuff. So we have to remove the disease segment, and you can see the disease segment. You can chop the entire rectum and the colon. Total proctocolectomy can be done. Right? If you chop the entire rectum and the colon, what is left in the patient? It is just the ileum which is left. And the ileum can be connected with the anal canal. If you connect ileum with the anal canal directly, beta, there is no reservoir where the intestinal contents can stay. God has given you rectum. God has given you sigmoid. These are the reservoirs. The fecal matter stays here for a long period of time. It is only because of the rectum and the sigmoid colon, beta, that you are getting only 1 or 2 opportunities in a day to go to the toilet and pass stools. If God does not give you this rectum and sigmoid, then there is no area where this fecal matter can stay. So whatever is coming, that has to pass. So the frequency of stool will be more, right? If you are connecting ileum directly with the anal canal, definitely the patient will have increased frequency of stools. And in ulcerative colitis, the problem to the patient is this bloody mucus diarrhea. So in these cases, what we can do is we don't connect the ileum with the anal canal directly. Either we can just take the ileum out on the abdominal wall as a permanent ileostomy. जिंदगी भर के लिए पेट की दीवार से ileum को बाहर निकाल देते हैं, permanent ileostomy, and then we just ask the patient to put a bag on the abdominal wall over this ileum, so that whatever intestinal contents are coming, they'll keep on collecting in the bag, and whenever the bag gets full, then the patient can just discard that bag and put another bag. However, age of this ulcerative colitis, as we saw, is 20, 25, 30 years of age. हो सकता है अभी इसकी शादी भी ना हुई हो, probably 20, 22, 23, 25 years. He is not married also, and you have done a permanent ileostomy in this patient. जिंदगी भर के लिए ileum पेट से बाहर निकाल दी है. You can imagine what would be the quality of life. So in these cases, what we can do, instead of doing a permanent ileostomy, we can try to create a reservoir from the ileum. We know that small intestine is 6 meters long. We can create some pouch or some reservoirs from the ileum, and then we can connect those pouches with the anal canal. This is called as ileal pouch anal anastomosis. Let me just see if there's a pouch type of thing here.
Ulcerative colitis, UC, is to rule out cancers.
See, what has been done?
The affected part of the colon.
What has been done here is, if suppose the entire rectum and the colon was diseased, then we are just chopping the rectum here and the terminal ileum here. So you are going to remove the entire rectum and the colon. This is rectum is procta. So total proctocolectomy is done. Now you are left with ileum and the anal canal. You know you cannot connect this ileum with the anal canal directly. Otherwise the patient will have intense diarrhea. So you either take this ileum out on the abdominal wall permanently as a permanent ileostomy, or you can try to create some pouch from the ileum. Like here we try to create a pouch from the ileum. They can be J-shaped pouch, inverted J-shaped pouch, M type of pouch, W type of pouch, and then this pouch is connected with the anal canal. This is called as ileal pouch anal anastomosis. Whenever we are connecting this pouch with the anal canal, we know beta, anal canal is a dirty area, there is always a high risk of infection in the pouch. Infection of the pouch should be called as, क्या बोलेंगे बेटा? Can you speak out from your mouth? Infection of the pouch. Pouchitis. A common complication of this pouch surgery is pouchitis. It is not poutitis. It is pouchitis. Right, beta? Okay, G. So let's take a look about what all is written in this inflammatory bowel diseases. Crohn's disease generally affects the terminal ileum, and ulcerative usually affects the rectum and then spread proximally. So I've just tried to make a diagram where you can remember that Crohn's is towards the right iliac fossa and ulcerative is more towards the left iliac fossa. Though we know that Crohn's can affect any part of GIT, right from mouth to anus. Okay, so if we take a look at the differences between Crohn's disease and ulcerative colitis, the other name for Crohn's is regional enteritis. Just like Burgess disease is called as thromboangiitis obliterans, MCQ people, they don't mention Burgess, they can mention thromboangiitis obliterans. Same way, the people, the examiners may not mention Crohn's, may just mention regional enteritis. Exact cause is not known, but it is thought to be autoimmune. Generally, the age group is 20 to 40 years, with a second peak in both around 60 years. Both are more common in white, rich, and Western countries. Both Crohn's and ulcerative are more common in Western countries, white people, rich people. Crohn's disease can affect any part of GIT. However, most commonly the terminal ileum and then the cecum. Second most part involved is the anal region. Crohn's disease is characterized by skip areas or skip lesions. That means Crohn's is not continuous. There are normal segments in between. While ulcerative colitis most commonly start in the rectum and then it spread proximally in continuity, depending on which part is getting affected. Proctitis, proctosigmoiditis, proctosigmoidocolitis, pancolitis or universal colitis, and if it spreads into the ileum, we call it as backwash ileitis. Crohn's disease is characterized by non-caseating granulomas, where we find serpentine ulcers and cobblestone mucosa. Stricture sinus fissure fistula is much more common in Crohn's disease. Important for Crohn's, it is transmural. That means all layers are involved. Mucosa, submucosa, muscle, serosa. All layers are involved. While ulcerative colitis involves mucosa and submucosa. It is a non-specific inflammation. It is characterized by collar button ulcers and pseudopolyps. Pseudopolyps is one of the characteristic feature of ulcerative colitis. Crohn's disease or regional enteritis can present with abdominal pain or maybe mass in the right iliac fossa, diarrhea, constipation, nausea, vomiting, depending on which part of the GIT is involved. Ulcerative colitis most often presents with diarrhea, which may be mucus and bloody diarrhea. Mild is less than 4 motions per day. Moderate is less than 6 motions per day. severe is less than 10 motions per day, and fulminant is more than 10 motions per day. Apart from this presentation, there may be extraintestinal manifestations in this Crohn's and ulcerative colitis, both Crohn's and ulcerative colitis. There may be extraintestinal manifestations, maybe involvement of joints, that is the polyarthropathy, ankylosing spondylitis and sacroiliitis. Eyes, there may be uveitis, scleritis. Skin, there may be pyoderma gangrenosum, erythema nodosum. Bile duct, there is a sclerosing cholangitis, like primary sclerosing cholangitis, PSC, primary sclerosing cholangitis. Primary sclerosing cholangitis is much more common in ulcerative colitis. Sclerosis means fibrosis. Whenever we talk about vessels, then instead of using the term fibrosis, we call sclerosis. And even cancers can develop. Cholangiocarcinoma. If we just try to imagine choledochal cyst in pediatric surgery, 3 complications of choledochal cyst: cholangitis, choledocholithiasis, cholangiocarcinoma. Most common site of cholangiocarcinoma is the hilum, that is the confluence of right-left hepatic duct. Hilar cholangiocarcinoma is also called as Klatskin's tumor. In the investigation spitta, investigation of choice for Crohn's would be CECT. For ulcerative colitis, it will be colonoscopy. If we are doing a contrast study, then for terminal ileum, we'll call it as barium meal follow-through, and for colon, barium enema. So when we are doing a barium meal follow-through in Crohn's disease, we may see a string sign of Cantor. String sign of Cantor. Simple string sign in the terminal ileum because of stricture is seen in TB of ileum, tuberculosis of ileum. While in ulcerative colitis, when we are doing barium enema, we find a lead pipe appearance. Whenever we have been drawing the colon, you might have seen that we are drawing the colon somewhat like this. These are haustral folds. In ulcerative colitis, these haustral folds are lost. So what happens? The colon actually looks as a single pipe. This is what is a lead pipe appearance. This is due to loss of haustral folds. Once the diagnosis is made, then we go ahead with the treatment for these Crohn's and ulcerative colitis. And in the treatment, the mainstay of treatment are the steroids. We can use 5-aminosalicylates in colonic disease, especially when there is inflammation, because 5-aminosalicylates, they are anti-inflammatory. We can use various immunomodulators like levamisole, monoclonal antibodies like infliximab, rituximab. Surgery is rarely done in Crohn's, but can be done in ulcerative colitis. When should we go for surgery? When there is failure of any medical treatment, steroid-dependent disease, extraintestinal manifestations, risk of cancer, which is more in ulcerative colitis, or there are complications like toxic megacolon, hemorrhage, and perforation. What surgery we do in ulcerative colitis? Suppose if the entire rectum and colon is involved, then we have to do a total proctocolectomy. पूरा का पूरा रेक्टम और कोलोन निकाल के फेंक दिया गया है. इसके बाद either we do a permanent ileostomy, जिंदगी भर के लिए पेट से आइलियम को बाहर निकाल दिया गया है, and then we have put a bag, or better would be if we can create a ileal pouch, that is the reservoir, and then connect with the anus. Ileal pouch anal anastomosis. This would be better, but this requires some surgical skill and expertise. So if we have got that, wonderful. Most commonly, the pouch made is a J pouch. We can make S pouch, W pouch, M pouch. A common complication of pouch surgery, what we come across is pouchitis, inflammation of the pouch, that is pouchitis. Apart from the story of this Crohn's and ulcerative colitis, a small story related to diverticulosis of colon. Now, this is something which we have understood nicely. Just a revision of what we discussed about the diverticulars earlier. Look at me on the screen. The story of different diverticulars in the body. Congenital diverticulars, acquired diverticulars, congenital which are present right from birth, acquired which are acquired later in life. Congenital diverticulars, we have to go into the intrauterine life, where when we were in intrauterine life, then our umbilicus had a connection with the intestine, that was a vitellointestinal duct or our own fellow mesenteric duct. There was a connection of our umbilicus with the urinary bladder, which was allantois, becomes the future urachus. If suppose, generally what happens, these connections of the umbilicus with the intestine and bladder, they close before birth. So after birth, like we all are sitting right now, we do not have any connection of our umbilicus with the intestine or bladder. But by chance, if suppose these connections persist after birth, suppose umbilicus intestinal connection persists after birth, this is an abnormal relationship and it is called as fistula. And then intestinal contents, that means maybe fecal or bilious or intestinal contents will come out of the baby's umbilicus. That is umbilical fecal fistula. If suppose the relationship between umbilicus and bladder persists after birth, then bladder urine will come out from the umbilicus, watery discharge come out from the umbilicus. This is umbilical urinary fistula. There have been other variations also. Sometimes only the umbilical end is patent, the intestinal end or the bladder end closes. In these cases, the mucus comes out from the baby's umbilicus, that is umbilical sinus. If suppose intestinal end remains patent and the umbilical end has closed, that is a Meckel's diverticula. That is a congenital intestinal diverticula. If suppose only the vesical end of this connection is patent and the umbilical end has closed, this is a congenital urinary bladder diverticula. So these are congenital diverticulars. In the acquired diverticulars, the stories are related to traffic jam situations. Whenever there is any traffic jam somewhere, the proximal people are going to get dilated. Pressure in the proximal part will increase. And if the supporting wall is weak, then the high pressure will force the mucosa to outpouch. And this is what is an acquired diverticulum. Congenital diverticulars are true diverticulars because they have got all the layers of the organ. But acquired diverticulars are false diverticulars because usually only the mucosa or maybe the superficial submucosa will outpouch. In adult surgery, we talked about a Zenkus diverticula in the pharynx. When the tone of the cricopharyngeal sphincter was tight, pressure in the pharynx more, high pressure forces the posterior pharyngeal wall to protrude out posteriorly through the Killian's dehiscens inferior constrictor thyropharyngeus cricopharyngeus muscle. And that is what is a Zenkus diverticula, the pharyngeal pouch or the cricopharyngeal achalasia. Here, the sigmoid colon diverticulars, constipated individuals, fecal matter getting impacted in the rectum, sigmoid colon dilated, pressure in the sigmoid colon high will force the mucosa of the sigmoid colon to outpouch, resulting in sigmoid colon diverticulars. We know as we grow older, the tissues become weaker and weaker. जैसे जैसे उम्र बढ़ती है, इमारतें कमज़ोर होने लगती हैं. That is the reason why these acquired diverticulars are commonly seen in elderly people. Now, let's take a look what all is written here. So, most commonly, these diverticulars are seen in the sigmoid colon. We also know, beta, that there is a mesentery which is actually bringing the blood vessels. If we try to take a look that on which border these diverticulars should be more common, if suppose this is the point of entry of blood vessels here, this border of the intestine, will be called as the mesenteric border, and this border of the intestine will be called as the antimesenteric border. Right? Now, MCQ people may ask that on which border these diverticulars are more common. So here we can see the point of entry of blood vessels into the wall of the colon makes the wall of the colon a weak area on the mesenteric side. So there are more chances of these diverticulars on the mesenteric border. Meckel's diverticula was more commonly seen on the antimesenteric border. Here, these diverticulars are more commonly seen on the mesenteric border. We know they are common in elderly people. We know they are acquired diverticulars. They are false diverticulars as they do not contain all the layers. The story of this diverticula is related to constipation. If the fecal matter remains here impacted for a longer time, pressure in the sigmoid colon will be high, and this will force the mucosa to outpouch. Patient can present with pain in the left iliac fossa and bleeding per rectum. Sometimes these diverticulars can get infected and diverticular perforation can occur. For example, if we just try to take a look at one of the videos that how this diverticular perforation can occur. Now see how the fecal matter is coming here. These are the diverticulars, what you see, the outpouchings. Can you see the pits? Now sometimes what happens when the fecal matter is coming, this is the diverticula here. This pressure of the fecal matter can force the diverticulars to move out. Once again, if we take a look.
The large intestine, or colon, forms feces, and as people age, certain conditions may develop. Diverticulosis occurs when small pouches form in the wall of the large intestine. Most people with diverticulosis don't have symptoms. It is often found through tests ordered for something else. When feces get trapped in the pouches and bacteria grow, inflammation and infection result. This is called diverticulitis.
Right, beta. So this is how the diverticulitis and diverticular perforation can occur. When we are doing a barium enema, then on barium enema, we see a classical appearance which has been asked in our MCQs. Because of the multiple outpouchings you are seeing here, this looks like a sawtooth. Saw is the carpenter's instrument which is using to cut the wood, right? जैसे कारपेंटर के पास आरी होती है ना बेटा, वो आरी लकड़ी काटने वाली, राइट? सो उसमें दांत निकले होते हैं. देयर आर मल्टीपल टूथ which you see in that carpenter's saw. So same type of appearance is what we are seeing in this colon here, and this is what we call as a sawtooth appearance. Sawtooth appearance. So on barium enema, you find a sawtooth appearance, and this has been asked as an image-based question in our exams. Though it is a radiology question, but yes, this is how the sawtooth appearance can be seen. Investigation of choice would be CECT, uh, of abdomen. Whenever we are suspecting diverticulitis or diverticular perforation, then we should not use barium enema. We have already discussed that contrast studies are avoided in GI perforations as far as possible, so we prefer getting a CECT done. In the treatment, not very specific. Initially, we can give high fiber diet, and later we can go for resection and anastomosis if there are any complications. So that is how we manage these diverticulars. This completes our iliac fossa story, and now we'll be coming into the hypogastrium story, where we'll be talking about bladder and urethral trauma and benign prostatic hyperplasia. So here what we'll do is we'll take a break, and we will be back at 1:45 p.m. Lunch break, we'll be taking lunch break, or you can say a long break, at around 3:15 p.m. Right, and then we'll resume the class maybe by 6 o'clock or 6:30 in the evening. Thank you, beta. Thank you very much for your patience. If you've got any queries, beta, you can just type those queries. On the last 5 digits, 56918, and Rutherford Morrison, we extend upwards and laterally. That is absolutely correct. We extend upwards and laterally. Beta, please do mention your name and university. Page 63, question number 3. The last 5 digits, 41905. Please do mention your name and university, beta. Page 63, question number 3. Beta, in this particular question, the patient is presenting with pain in gluteal region, buttocks, thighs, and leg on both the sides. If the patient is having an issue on both the sides, beta, and he is also saying that pulses in both the lower limbs are absent, just have a look at the aorta, and if there is a aortoiliac obstruction, then only the pulses in both the lower limbs will be absent. So if there is a aortoiliac obstruction, that means the obstruction is suprainguinal, and for suprainguinal vascular obstructions, we prefer using a Dacron graft. If we are not sure, beta, Prashant, please do mention your university. If we didn't get the rebound tenderness or tenderness, then first we do a ultrasound. Very good question, beta. If you are listening to me right now, in pregnancy, we do treatment for acute appendicitis. We do emergency appendicectomy, whatever is the trimester. If the appendix is acutely inflamed, we do emergency appendicectomy in that trimester, though the safest one is second trimester. Uh, there is hardly any function of appendix except for some immune function, the lymphoid follicles. So even after appendicectomy, the patient is not going to have any major challenge. Dishit from Orenburg, like in gallstone, if there is severe infection, we first reduce and then we go for remove. If there is urine stone, yeah, we have to follow the same rule in urinary tract also. If suppose there is huge amount of infection in the urinary tract, for example, proximal hydronephrosis, pyonephrosis, then first we do a PCN, percutaneous nephrostomy, drain the pus, and once the infection settles, then we opt for removing the stone. That is a general principle, Peter, that is followed everywhere. Wonderful. Priya from Philippines, beta, please do mention your university in Philippines. You have a question like omentum is adhering the appendix or any inflamed organ, then why there will be burst in appendix? Yeah, it should protect the appendix, beta, but if the bacterial party becomes a bit more aggressive than the protection, then it can burst. It simply depends on the aggressive nature of the bacterial party, beta. For emergency appendicectomy, if suppose the patient is presenting with uh, severe symptoms like severe pain, maybe tachycardia, maybe high temperature, maybe the TLC count somewhere around 14,000-15,000, then yes, we are doing the emergency appendicectomy. Ilya from Manila. Very good afternoon, beta. What will the treatment in pregnant women with more than 5 millimeter renal stone? More than 5 millimeter renal stone, if the lady is not facing too many problems, let her continue with pregnancy and we can remove these renal stones once the delivery has been done. Thank you, beta. Srideep from Gomel, your doubt clinical symptoms of appendicitis because we can't find rebound tenderness or tenderness. Yes, beta. Generally, it depends on the trimester, or you can say the location of the uterus, which month pregnancy she is in. So depending on that, the appendix is going to be pushed to the peripheries and upwards. So whatever you are finding in the right iliac fossa, that you will be finding a little more laterally and upwards. Anubhuti from Gomel, beta, please do send the exact questions. What time we were supposed to be back? Okay, we have got some time. Anish from KNMU, beta. I hope this is Kazakh National Medical University. The DJ stenting and endourinary stenting, beta. We just pass a cystoscope into the bladder. Through the side channel of the cystoscope, we take that DJ stent and just introduce it into the ureter. There's a wire which is put inside the DJ stent before we put the DJ stent into the ureter. So we straighten those coils of DJ stent with the help of the wire inside the DJ stent, and then we push the DJ along with the wire. So the DJ would be going right up to the kidneys. Then we just withdraw the wire. So one end of the DJ is in the kidney. As soon as you withdraw the wire, the kidney end will get coiled inside the kidney, and the DJ stent will be holded in the kidney. And then when the wire is being withdrawn, the other end of the DJ is in the bladder. As soon as you remove the wire from inside the DJ, from the bladder area also, then the bladder end of the DJ will get coiled inside the bladder. Ahmed from Orenburg, beta. What is the length of the incision that is done in appendicectomy? It is roughly around 3 centimeters. For extended one, we can go up to 7 centimeters or 8 centimeters. Beta 46006, please do mention your name and university. How will we decide what is to make whether muscle? We make muscle splitting incision, beta. We make a McBurney's incision only. However, if there is any preoperative finding to suggest that we are going to find a difficult appendix, or when we have made the McBurney's, we can extend it to the other incisions. Generally, Alvarado is not going to help, but yes, CECT can help. Angiodysplasia of colon is more commonly seen on the right side in the ascending colon, Praveen. I think let me take a break quickly and let me be back. Okay. Right, beta. So now let's take a look at the hypogastric stories. In the hypogastrium, herein we'll be talking about the bladder and urethral trauma, beta. This is something which is actually related to trauma. But I thought to cover this bladder urethral trauma here so that once we are able to understand where is the bladder and all that stuff, then the life becomes a little more easier. And now if we take a look here, now it's fine. Just a moment. Right, beta. So bladder and urethral trauma, if we just try to take a look what we want to understand in this story regarding the urinary bladder, beta. If we look at the urinary tract, then we all know that God has given the kidneys here in the retroperitoneum, and then there are ureters which are actually traveling in the retroperitoneum, and then the ureters actually come anteriorly, right? And then they come into the lower part here, and here is the bladder. All this kidney, ureter, bladder, this is outside the peritoneal cavity, right? So bladder, which is located here, this is also extraperitoneal, right? The peritoneal reflection is just coming and crossing over the top of the bladder. That is the dome or fundus. That is the top part of the bladder. Now, if we talk about bladder traumas, then bladder traumas, majority of them will be in the extraperitoneal part only, because bladder is extraperitoneal. And you also know that God has given you pelvic bone here, the ilium, ischium and the pubic bone. So in road traffic accidents, whenever there is a fracture of the pelvic bone, especially of the pubic bone, then this fractured pubic bone can cause injury to the bladder. That is the commonest cause of extraperitoneal bladder rupture. And sometimes we can find some blood drops trickling on either side of the bladder neck, which we call as teardrop bladder. कभी कभी जब ये pubic bone टूटती है और ब्लैडर को इंजर करती है तो एक्स्ट्रा पेरिटोनियल पार्ट में इंजर करती है, और कभी कभी ये खून की बूंदें ब्लैडर के बाजू से ब्लैडर नेक के दाएं बाएं गिरती हैं. ऐसा लगता है ब्लैडर खून के आंसू रो रहा है, जिसको हम टीयर ड्रॉप ब्लैडर बोलते हैं. Obviously in bladder ruptures we have to make an incision in the lower part of the abdomen, just like we make an incision for cesarean section, which we also called as Pfannenstiel incision, and we can repair these bladders. One thing which I want to tell you beta, whenever you are putting sutures on the bladder, जब भी ब्लैडर के रिपेयर में ब्लैडर में टाँके लगाते हैं, we should have this in our mind that urine would be continuously coming in the bladder, and if you are putting sutures in the bladder, the sutures will be becoming wet and there will be chances that these wet sutures can break. जब भी हम ब्लैडर का ऑपरेशन करते हैं और ब्लैडर में टाँके लगाते हैं, हम जानते हैं कि कंटिन्यूसली यूरिन ब्लैडर में आता है, और यूरिन की वजह से ब्लैडर में लगाए गए टाँके गीले हो सकते हैं और गीले टाँके टूट सकते हैं. It is because of this reason that whenever we are doing any bladder surgeries, we have to leave a Foley's catheter after bladder operations, so that this Foley's catheter continuously keeps on draining the urine out and the sutures do not become wet and the area can heal properly. We keep these Foley's catheter for approximately 7 to 10 days after bladder operations, wherever we are putting sutures in the urinary bladder. Right. There is a rare situation which we can come across in bladder traumas. Sometimes what happens, if suppose the bladder is over distended, like just imagine Friday night or Saturday night, rainy evening, little cold weather, 4 friends sitting with beer. जस्ट इमेजिन करिए बेटा, शुक्रवार या शनिवार की रात है, बारिश हो रही है, मौसम ठंडा है और 4 दोस्त बैठे हुए हैं बियर के साथ. नाउ if suppose the bladder gets overdistended and suppose one friend gives a blow into the lower abdomen of his friend just like that, अचानक मजाक मजाक में एक दोस्त अपने दूसरे दोस्त के पेट में ऐसे घूसा मारता है, क्या बात करता है. Now, if suppose the bladder was overdistended and suddenly there is a blow in the lower abdomen, this bladder can rupture. And then since the bladder was overdistended, then this top of the bladder would have been peeping inside the peritoneal cavity. And suddenly when the bladder ruptures intraperitoneally, all the urine in the bladder will leak into the peritoneal cavity. Sudden volume loss, patient may go into a syncope type of situation. Patient may present with severe pain in the hypogastrium. Now you are the doctor in the emergency, patient coming to you with this type of history that there was a trauma to the lower abdomen and probably the bladder was overdistended before the trauma. And now when you examine, the patient is having severe pain in the hypogastrium. What you can do is you can simply put a needle in the peritoneal cavity, aspirate, and if that reveals urine, that means there is urine in the peritoneal cavity. And since you know that kidney, ureter, bladder, everything is outside the peritoneal cavity, if you find urine inside the peritoneal cavity, there are high chances with this history that bladder has ruptured intraperitoneally. Obviously, if there is an intraperitoneal bladder rupture, you will have to do a laparotomy, maybe a lower midline laparotomy. You will do a peritoneal lavage and remove the urine and then repair the bladder, leave a Foley's catheter for 7 to 10 days. That is how we manage the bladder ruptures. Let's take a look. So, intraperitoneal bladder rupture, this is less common, just 20%. This is trauma to overdistended bladder, may be associated with beer drinking or sometimes during lower abdominal operations also. For example, if suppose cesarean section was being done and bladder was not emptied, suppose Foley's catheter was not put in the bladder and cesarean was being done, then when the gynecologist is making an incision to reach to the uterus and deliver the baby, before the uterus there is bladder. If the bladder is overdistended, she might land up in cutting the bladder before she reaches the uterus. So it is mandatory whenever we are doing any lower abdominal operation, we have to put a Foley's catheter in order to drain all the urine from the bladder so that the bladder is decompressed totally and the chances of injury are not there. If there is intraperitoneal bladder rupture, then there is sudden hypogastric pain associated with some syncope. You can simply put a needle in the peritoneal cavity and this will reveal urine. To confirm, you can just do a contrast study. You can push the contrast inside the bladder. For example, you put a Foley's catheter into the bladder, suppose, and push the contrast inside the bladder and take the Foley's catheter out. The bladder would be full of contrast. And if there is any rupture of the bladder, then obviously the contrast will be found leaking from that rupture and the contrast will be seen inside the peritoneal cavity. That is how we can confirm these bladder ruptures by cystogram. And the treatment, we have to do a lower midline laparotomy because urine is in the peritoneal cavity, so we have to go inside the peritoneal cavity. Lower midline laparotomy. Peritoneal lavage. Bladder repair. and leave a Foley's urethral catheter for 7 to 10 days. Majority of bladder ruptures, 80% of bladder ruptures are extraperitoneal, as bladder is extraperitoneal, and usually these extraperitoneal ruptures are related to road traffic accidents, especially in pelvic fracture. And sometimes in extraperitoneal bladder ruptures, we find blood drops trickling from the side of the bladder neck as if the bladder is weeping blood. Teardrop bladder is a feature of extraperitoneal bladder rupture, and the treatment here again would be a bladder repair. We can do the same cystogram beta to see the leakage of contrast from the bladder. We know nicely that for bladder the contrast study is cystogram. For urethra it is retrograde urethrogram. Right. लिख लिया बेटा. Now we move forward towards the urethra, and in the urethra beta, if we just try to take a look at the anatomy, this is suppose the urinary bladder. Now here suppose is the urethra. You know the different parts of male urethra. Here lies the prostate gland. Right. This is the posterior urethra. This is the anterior urethra. In the posterior urethra, that part of posterior urethra which lie within the prostate, this is the prostatic urethra, and this part is the membranous urethra. All this is posterior urethra. This is the anterior urethra. That part of urethra which lie within the perineum is called as perineal or bulbar urethra. That part of urethra which lie within the penis, this is the penile urethra. Now, if we take a look at the posterior and anterior urethras, in posterior urethra, this part is protected by prostate, so this does not suffer from injury commonly. That means common part injured in posterior urethra will be this membranous urethra. And this injury generally is seen just at the apex of prostate, just at the termination of prostate, we find injury in these posterior urethras. Okay, so this is the membranous urethra which is getting injured in posterior urethra. Same way beta, in anterior urethras, penile urethra is something which is protected by the penis, so the chances of injury to penile urethra are less. But whenever there is any injury to the perineum, any blow to the perineum, then perineal urethra is commonly injured, bulbar urethra is commonly injured. That means in posterior urethra, it is the membranous. In anterior urethra, it is the bulbar or the perineal urethra which is commonly injured. Out of anterior and posterior urethras, that means out of this versus this, perineal urethral injuries are more common. Bulbar urethral injuries are more common. The posterior urethral injuries are actually commonly associated with pelvic fracture. The same story what we are talking about the urinary bladder. Whenever there is a road traffic accident, pelvic fracture, the pelvic bone, pubic bone can cause injury to the bladder or to the posterior urethra, right? If we talk about anterior urethra injuries or the perineal bulbar urethral injuries, any blow to the perineum will cause that. For example, beta, we have commonly seen these injuries like suppose, let us just imagine that a person was actually walking on the footpath. It was dark at the night, रात का समय था. अंधेरे में एक भाई साहब थे जो चले जा रहे थे अपनी धुन में गाना गुनगुनाते हुए. And sometimes, as we know about the Indian roads also, that usually the lighting on the roads is not proper. So sometimes what we can come across, ये भाई साहब जो थे ये सड़क पे ऐसे गाना गुनगुनाते हुए जा रहे थे. जो सड़क पे फुटपाथ पे गटर होते हैं, the gutters on the footpath, this is the manhole and there is a cover on the manhole. Many a times these covers are either not there, or if they are there, they might be loose. Now this gentleman who was walking on the road was staring at some girl who was passing by. ये भाई साहब गुनगुनाते हुए गाना गुनगुनाते हुए रोड पे मस्ती से चल रहे थे, किसी लड़की को देख रहे थे. अचानक से इनका पैर इस पे पड़ता है और फिर आप देखिए इनके साथ क्या होता है. Now you can see here what has happened. कहीं पे निगाहें, कहीं पे निशाना. Looking London, talking Tokyo. देख कुछ और रहे थे, हो कुछ और गया. What has happened? There is a blow to the perineum. And you can very well understand now what is going to happen. There is an injury to the perineum. This will cause injury to the perineal urethra or the bulbar urethra. There are so many incidences, beta. First I'll tell in Hindi. बचपन की कुछ यादें ताज़ा हो जाती हैं. जब बॉयज़ की अगर हम बात करें तो छोटेपन में जब हम साइकिल चलाना सीखते थे, उसके बाद अपने दोस्तों के साथ खूब साइकिल चलाया करते थे. डंडे वाली साइकिल हुआ करती थी और कई बार बचपन में दोस्तों के साथ उस साइकिल पर रेस लगाया करते थे. जब हम फुल स्पीड में साइकिल चला रहे होते थे, अचानक से मान लो साइकिल की चेन स्लिप हो जाती थी, तो हमारा जो पेरिनियम होता था वो सीधा डंडे पे आ जाता था और उससे पेरिनियम को चोट लगती थी. आई रिपीट दिस इन इंग्लिश. If we just try to imagine the childhood stories when we used to learn the bicycles, when we used to ride those bicycles, especially when we were racing with our friends, many times when we were riding the bicycle in full speed and suddenly suppose the chain of the cycle slips and the perineum comes on that shaft of the bicycle, that would hurt the perineum. That can lead to perineal bulbar urethral injuries. Or just imagine a person who is falling from a height. कोई बंदा है जो मान लो 20वें फ्लोर से गिर गया है, 20वें फ्लोर से गिर रहा है या दूसरे फ्लोर से गिर रहा है, तीसरे फ्लोर से गिर रहा है. Somebody is falling from a height, maybe second floor, third floor. Then also there are chances of injury to the perineum. So any perineal urethral injury will have the risk of this bulbar urethral rupture. Now what is going to actually happen in these patients? Whatever is the injury, whether it is the posterior urethra or the anterior urethra, we can imagine that urine is coming in this area. Urine is coming here and we can find the leakage of urine. If there is an injury here, then there will be leakage of urine here in this area. In this case, the urine is getting collected in the true pelvis. This part is in the pelvis. But if there is an injury here, then the urine will be coming here and then the urine will be leaking into the perineum. So you will find urine collection in the perineum, or this may even trickle down around the penis, right? Apart from this, many a times it is not only the urine, but we may also find the blood getting collected here or in this injury here. So here the blood is getting collected in the pelvis, hematoma in the pelvis, pelvic hematoma. Here the blood is getting collected in the perineum, perineal hematoma. And many a times, beta, in urethral injury, we may find these blood drops trickling out from the external urethral meatus. So you may find this blood trickling from the external urethral meatus. These can be the presentations. an important thing to understand or make a note of. Sometimes what happens, whether it is a posterior urethra or an anterior urethra injury will cause inflammation. Inflammation, rubor tumor, calor dolor. Tumor means swelling. So there is a possibility that because of the injury, there might be swelling in this particular area, or maybe in this particular area. And because of this swelling in this area, it will cause narrowing of the urethra, whether here or here. That means if this is causing a traffic jam type of situation, the urine which is coming from the bladder will not be able to come down easily. Now the urine is not coming down easily. Some amount of urine would definitely be leaking, but whole urine will not be coming out. That means the urine will be getting collected inside the bladder only, and because of this, the bladder is going to get distended with urine, and this patient may present with retention of urine. If there is retention of urine and there is a urethral injury suspected, we know that in the treatment of retention of urine, first what we should do is we should try to pass a Foley's catheter from below. If you pass a Foley's catheter from below and you are able to negotiate it into the bladder, wonderful. But there is a problem. Sometimes what happens, if you're trying to pass a Foley's catheter, there is a possibility that Foley's catheter is going somewhat like this, and if there is an injury here, the Foley's catheter may come out of the injury here. Now when you try to inflate the balloon of the Foley's catheter, the balloon may be lying exactly at the site of injured urethra. If you try to inflate the balloon here, the injury can widen. So it is recommended that instead of passing a Foley's urethral catheter in patients presenting with retention of urine and suspected urethral injury, it is better to avoid passing the Foley's catheter. You can simply put a supracath from above. You can just put a catheter from above and do a suprapubic cystostomy. By this, you can relieve the retention, plus you will avoid any chance of injury to urethra. Let the stories settle, let the inflammation heal. Majority of the time, the healing of this injury will occur by fibrosis. A stricture will form in the urethra till the time the patient is having a suprapubic cystostomy. Once the stricture has formed, then you can do the treatment for these strictures. That is how we manage the urethral injury. So, if we talk about the rupture of urethra, posterior urethra and anterior urethra, out of these two beta, most common urethral rupture is the anterior urethra. And in anterior urethra, it is the perineal or the bulbar urethra which ruptures most commonly. Posterior urethra, it is the membranous urethra which ruptures. Most commonly it is due to road traffic accidents or pelvic fracture, most commonly near the apex of prostate. Near the apex of prostate. And you can very well understand, beta, that if there is an injury at this area, because of swelling and edema, the prostate gland will be pushed slightly higher up. When we are doing a digital rectal examination in these posterior urethral injuries, then we may find a high-lying prostate. For example, if you are doing a digital rectal examination somewhat like this, just have a look. You are putting your finger in the rectum, right? This gland, what you're seeing here, this is a prostate gland. If I say there is an injury to the membranous urethra here, because of swelling in this area, it will push the prostate gland up. So on digital rectal examination, normally you are able to feel the prostate here, but because of swelling, the prostate is pushed up and you will feel a high-lying prostate. So a high-lying prostate is suggestive of posterior urethral or membranous urethral injury. On digital rectal examination, you will find a high-lying prostate. The classical features what we come across in urethral injuries: retention of urine can be there, hematoma can be there, and blood can be seen at the external urethral meatus. If we are talking about posterior urethra, then blood will get collected in the pelvis, so a pelvic hematoma. Urine gets collected in true pelvis. Urine gets collected in true pelvis in posterior urethral injuries. To see the urethral injury, we can do a retrograde urethrogram. For retrograde urethrogram, well, this is an image of retrograde urethrogram. Something like this was asked on 4th of June 2022. Here we are just putting a catheter, maybe just for 1 centimeter here, and then we are pushing the contrast. The contrast will be traveling through the entire urethra, and here you will be seeing the contrast going inside the bladder. So that is how you can read the urethra, and this is what is a retrograde urethrogram. So again, here it is advised, beta, that please do look at the various images of retrograde urethrogram so that you get a clear-cut idea that how the urethra actually looks like on a contrast study. This what you are seeing is the urinary bladder. If I say that there is a posterior urethral injury, you will see the leakage of contrast from the site of rupture. If it is a perineal urethral injury, you will see the leakage of contrast from this perineal urethral injury area. One word answer for patients presenting with retention of urine and suspected urethral trauma, we prefer doing a SPC, that is suprapubic cystostomy. And the instrument what we use for a suprapubic cystostomy, the name of the instrument is SupraCath. SupraCath. If we try to take a look and find out how the SupraCath actually looks like, this is a SupraCath. Wherein I was just telling you that it is just like a pen. You can just put your pen into the bladder, but no, not like this. We have to introduce it slowly and slowly under local anesthesia. We keep on puncturing through the anterior abdominal wall. There is a balloon, what you can see here. Once this part goes inside the bladder, the urine will start coming out from here. There is a trocar which is put inside. You remove the trocar, and now you just push the plastic catheter inside. Through this channel, you can push the saline, which will inflate the balloon inside the bladder, and then this SupraCath will get stuck inside the bladder. And then you can fix it with the skin with the help of sutures. So that is how SupraCath can be used. Regarding anterior urethra or perineal bulbar urethral injuries, this is the most common urethral rupture. Any injury to the perineum may be loose manhole cover, bicycle accident, or the MCQ like fall from height. Though this can cause injury anterior and posterior urethra both, but more often fall from height causes injury to the perineal urethra. The same triad beta what is mentioned above, retention of urine, hematoma and blood at the external urethral meatus. The only difference here is there will be collection in the perineum. So it will be a perineal hematoma, and in these cases urine will get collected in the perineum, or we can say in the scrotum, penis, and this urine can seep in the lower abdominal wall as well. Investigation of choice is the same, retrograde urethrogram, and the treatment is same, suprapubic cystostomy or SPC. This image what you are seeing in your workbook, this is just an image to show how the supracath is inserted. So first what we can do is we can just pass a guide wire into the bladder. Over the guide wire we can just load this catheter and then put the catheter inside, inflate the balloon inside the bladder so that the catheter gets stuck inside the bladder. That is how suprapubic cystostomies are done. So this is how we manage the bladder urethral traumas. One thing which is crucial here to remember in the exams beta, if there is a suspected urethral trauma and patient comes to you with retention of urine, please do not force any Foley's urethral catheter. No means no. Do not force the Foley's urethral catheter. It is better to do a suprapubic cystostomy. Otherwise, if you try to force the Foley's urethral catheter and inflate the balloon, then this can lead to widening of the urethral injuries. Moving further in this area, let's take a look about the prostate. Benign prostatic hyperplasia, very common problem. We know that after 60 years of age, many males, sometimes even 50% of males, they suffer from this benign prostatic hyperplasia. Why this happens, exact reasons are not known, but probably we have seen that there is overactivity of an enzyme 5-alpha reductase, and this 5-alpha reductase converts testosterone into 1,5-dihydrotestosterone. 1,5-dihydrotestosterone is considered to be 20 times more potent than testosterone in causing the enlargement of prostate. जैसे जैसे उम्र बढ़ती है 60-70 साल की उम्र में लगभग आधे मेल्स में प्रोस्टेट ग्लैंड बढ़ने लगता है. क्यों बढ़ता है इसका एग्जैक्ट कारण तो नहीं पता, लेकिन ये देखा गया कि एक 5-अल्फा रिडक्टेज एंजाइम होता है जिसकी एक्टिविटी प्रोस्टेट में अचानक से बढ़ जाती है, जो टेस्टोस्टेरॉन को 1,5-डाइहाइड्रोटेस्टोस्टेरॉन में कन्वर्ट करता है, और ये 1,5-DHT जो है ये 20 गुना ज़्यादा शक्तिशाली है टेस्टोस्टेरॉन से प्रोस्टेट की ग्रोथ कराने के लिए. और अगर प्रोस्टेट बढ़ने लगेगा तो फिर हम जानते हैं normally prostate is like this. So there is a nice diameter of the prostatic urethra. But if suppose the prostate gland enlarges, then the diameter of the prostatic urethra may reduce, and then the patient will have difficulty in passing urine. The proximal people are going to get dilated. Again you will say, sir, aap traffic jam batate rehte ho. But this is the simple story beta. There's a traffic jam situation again, and the proximal people are going to get dilated and they can cause different problems. Let us enjoy another video related to BPH.
The prostate is a small exocrine gland of the male reproductive system. It is located just below the urinary bladder, where it wraps around the first part of the male urethra. The prostate gland produces a milky fluid that is expelled into the urethra to mix with spermatozoa during ejaculation. The fluid serves as a lubricant and nutrition for sperm. Benign prostatic hyperplasia, BPH, also known as benign prostatic hypertrophy or enlarged prostate, is a condition in which the size of the prostate gland is increased. It is considered benign because it's not a cancer, and it does not increase the risk of cancer. However, when it becomes sufficiently large, the prostate tissue may compress the urethra and block the urine flow, causing a number of urination problems and urinary tract infections. BPH is very common in aging men. About 50% of men have some degree of BPH by the age of 60, with half of them demonstrating clinically significant symptoms. BPH is a result of hormonal changes and is considered a normal part of male aging. In aging prostate tissue, the rate of cell proliferation induced by male hormones somehow exceeds the rate of programmed cell death, or apoptosis. This results in an increased number of cells and enlargement of the prostate. There are two main classes of medication for BPH treatment. Alpha blockers. These drugs relax smooth muscle in the prostate and bladder neck, thus relieving the blockage of urine flow. 5-alpha reductase inhibitors. These inhibit local production of dihydrotestosterone, or DHT, the hormone that is responsible for prostate enlargement. For those who do not respond to medication, minimally invasive treatments are available. These non-surgical therapies use heat to cause cell death, or necrosis, in prostate tissue. The heat is delivered in small amounts and to a specific location to minimize unwanted damage. Different procedures differ mainly in the type of energy used. Transurethral resection of the prostate is a surgical procedure for removal of prostate tissue through the urethra. This procedure has been around for a long time and is still considered the gold standard for treatment of severe BPH. Nowadays, it is usually performed when medications and less invasive methods fail. The prostate is a small exocrine gland of the male reproductive system. It is located just below the urinary bladder, where it wraps around the first part of the male urethra. The prostate gland produces a milky fluid that is expelled into the urethra to mix with spermatozoa during ejaculation. The fluid serves as a lubricant and nutrition for sperm. Benign prostatic hyperplasia, BPH, also known as benign prostatic hypertrophy or enlarged prostate, is a condition in which the size of the prostate gland is increased. It is considered benign because it's not a cancer, and it does not increase the risk of cancer. However, when it becomes sufficiently large, the prostate tissue may compress the urethra and block the urine flow, causing a number of urination problems and urinary tract infections. BPH is very common in aging men. About 50% of men have some degree of BPH by the age of 60, with half of them demonstrating clinically significant symptoms. BPH is a result of hormonal changes and is considered a normal part of male aging. In aging prostate tissue, the rate of cell proliferation induced by male hormones somehow exceeds the rate of programmed cell death, or apoptosis. This results in an increased number of cells and enlargement of the prostate. There are two main classes of medication for BPH treatment. Alpha blockers. These drugs relax smooth muscle in the prostate and bladder neck, thus relieving the blockage of urine flow. 5-alpha reductase inhibitors. These inhibit local production of dihydrotestosterone, or DHT, the hormone that is responsible for prostate enlargement. For those who do not respond to medication, minimally invasive treatments are available. These non-surgical therapies use heat to cause cell death, or necrosis, in prostate tissue. The heat is delivered in small amounts and to a specific location to minimize unwanted damage. Different procedures differ mainly in the type of energy used. Transurethral resection of the prostate is a surgical procedure for removal of prostate tissue through the urethra. This procedure has been around for a long time and is still considered the gold standard for treatment of severe BPH. Nowadays, it is usually performed when medication and less invasive methods fail.
Right, Bida. So we got an idea that what is actually BPH and what is going to happen to the patient. As we discussed, that after 60 years of age, almost 50% of the males suffer from this benign prostatic hyperplasia. And the exact cause is not known, but it is believed to be the overactivity of this 5-alpha reductase, so that more 1,5-dihydrotestosterone is formed. Sometimes it may be related to estrogenic steroids also. The problem which we are seeing here is narrowing and lengthening of the prostatic urethra. Herein I would like to mention that weight of prostate is approximately 20 grams. And this BPH occurs in the transitional zone. BPH occurs in the transitional zone. There are different zones inside the prostate. Cancer of the prostate occurs in the peripheral zone. BPH causes enlargement of median lobe and lateral lobes, while cancer causes enlargement of the posterior lobe. Actually speaking, beta, there are 5 lobes in the prostate, 1 anterior, 1 posterior, 2 lateral, and 1 median. BPH causes enlargement of the median lobe and the lateral lobes, while cancer, which occurs in the periphery, causes enlargement of the posterior lobe. Now, because of this enlargement of prostate, traffic jam in the urethra, the patient can present with various lower urinary tract symptoms. And these lower urinary tract symptoms, they are also called as LUTs. These lower urinary tract symptoms can be related to either storage problems or voiding problems. Now, if the prostate is enlarged, it is pressing the urethra, so obviously there would be more storage taking place, more irritation of the bladder, that will cause more frequency of micturition. So the commonest symptom of BPH, what we come across, is frequency of micturition. Most common clinical presentation of BPH is frequency of micturition. This frequency is more often seen at night times, which we call as nocturia. And sometimes when the prostate enlarges, then there is a possibility that sometimes these patient experiences urgency. Now, urgency means urgency. Now he cannot wait. He has to go to the toilet to pass urine. And sometimes before he is able to reach to the toilet, he may pass few drops of urine in his underclothes. That is called as urge incontinence. So problems related to storage in BPH, frequency of micturition, more common at night times, nocturia, urgency and urge incontinence. There may be symptoms related to voiding. Voiding means when the patient is actually inside the toilet and is trying to pass urine. Now just close your eyes and just try to imagine the prostatic urethra. The prostate gland has enlarged. The prostatic urethra is narrow. 70-year-old gentleman inside the toilet. When he has entered into the toilet, he is trying to pass urine, but because of the enlarged prostate, the prostatic urethra is narrow. He might take some time to relax himself, to relax the sphincter, to relax the prostatic urethra. So till that time, the urine is not coming out. Maybe few seconds or sometimes even 1 minute or 2 minutes. This waiting time, this starting problem, initiation pause is called as hesitancy. 70-year-old gentleman inside the toilet, he might have to wait for some seconds or a minute before the urine starts coming out. This is hesitancy. Now, when the urine starts coming out, you can imagine the diameter of prostatic urethra is narrow. So the urine which is coming down, that stream will also be narrow. This is called as poor flow. This is the most troublesome symptom of BPH. Why? Because this particular gentleman, when he was young, like all of you, beta, all the boys who are sitting right now in the session, when you go to the toilet As soon as you enter into the toilet, immediately there is no starting, pause, nothing. Immediately the stream comes out, and the quality of the stream, the caliber of the stream, or the diameter of the stream is nice, and it goes right away from you. I repeat this in Hindi, beta. जितने भी बॉयज यहाँ पे बैठे हुए हैं, इस सेशन को देख रहे हैं, यंग एज में आप लोगों में अभी क्या होता है, आप जैसे ही टॉयलेट के लिए जाते हैं, जैसे ही टॉयलेट में घुसते हैं, तुरंत एकदम से कोई आपको वेट नहीं करना पड़ता, यूरिन एकदम से निकल आती है, और ये यूरिन जो है मोटी धार में निकलती है और आपसे दूर गिरती है. लेकिन what will happen in a patient of BPH? Because the prostatic urethra has become narrow, this old gentleman might have to wait for some time, hesitancy, and when the stream starts coming out, because of the narrow prostatic urethra, the quality of this urine stream will also be quite poor, and the urine will not be going away from his legs, rather urine is falling very close to the legs, sometimes on the legs itself. 60-70 साल की उम्र में जब प्रोस्टेट ग्लैंड बढ़ गया है, प्रोस्टेटिक यूरेथ्रा को दबा रहा है, इन लोगों में जब ये टॉयलेट में जाते हैं तो प्रोस्टेटिक यूरेथ्रा के दबे होने की वजह से इनको कुछ सेकंड्स या मिनट का इंतज़ार करना पड़ता है. इसको अपन हेजिटेंसी बोलते हैं. और जब ये यूरिन की धार आना शुरू भी होती है तो चूंकि प्रोस्टेटिक यूरेथ्रा दब गई है तो यूरिन की धार जो है वो बड़ी पतली होती है, और ये धार जो पहले दूर गिरा करती थी अब पैरों के पास गिरती है, कभी कभी तो पैरों पे कपड़ों पे गिर जाती है. This is poor flow, and this is the most troublesome symptom in BPH patients. Sometimes in these situations, when the quality of the stream is poor, narrow stream falling almost onto the legs of the patient may get frustrated and he would like to pass more urine quickly. He might strain in order to pass more urine. As soon as he strains, the lobes of the prostate, they come even close to each other on straining, and then the prostatic urethra shuts down. Whatever urine was coming earlier, even that urine stops now. This is called as intermittency. जब इनकी धार पतली पतली आ रही थी, 1 मिनट, 2 मिनट, 3 मिनट, फ्रस्ट्रेशन का लेवल बढ़ता जा रहा है, क्योंकि पहले वो सुनहरे दिन याद आ रहे हैं कि कब कैसे मोटी धार आया करती थी, पैरों से दूर गिरा करती थी, और अब ये पतली पतली धार पैरों के पास गिर रही है. चाहते हैं कि ये धार मोटी हो, चाहते हैं कि ये धार पैरों से दूर गिरे, जोर लगाते हैं, और जोर लगाने पे जो प्रोस्टेट के लोब हैं वो और एक दूसरे के नज़दीक आ जाते हैं, जिससे कि प्रोस्टेटिक यूरेथ्रा बंद हो जाती है और जो आ रही थी वो भी बंद हो जाती है. इसको हम इंटरमिटेंसी बोलते हैं. नाउ दिस ओल्ड जेंटलमैन रियलाइजेस दैट स्ट्रेनिंग इज नॉट गोइंग टू इम्प्रूव द यूरिन स्ट्रीम. Now he just relaxes himself and tries to satisfy himself with whatever is coming out. अब इनको समझ आ जाता है कि जोर जबरदस्ती करने से कुछ ना होने वाला, जो आ रही है उसी से संतोष करने की कोशिश करते हैं. This is the classical presentation of BPH patients. If we take a look in the voiding stories, there is hesitancy. Poor flow is the most troublesome symptom. And when they try to strain, the urine stops. Sometimes there can be dribbling and retention of urine. So these are the lower urinary tract symptoms. Symptoms related to storage and voiding. Most common being frequency, but the most troublesome symptom is poor flow. When these old gentlemen come to you in your OPD February 23, what you are wearing in February 23 in the hospital? Very good, white coat and that stethoscope. Now you take the history from these patients nicely. On history you are getting an idea that boss, the prostate gland might be enlarged. You can confirm by doing a digital rectal examination. You can feel that enlarged prostate. However, investigation of choice can be ultrasound of the abdomen, which can tell you about the volume of prostate. On ultrasound, we can also measure the post-void residue. Post-void residue means after micturition, how much amount of urine remains inside the bladder. यूरिन करने के बाद ब्लैडर में कितना बचता है. Ideally, in a normal person, if you pass urine, there should not be any urine remaining inside the bladder. Ideally, the value of post-void residual urine should be 0. But generally, we have seen 15-20 ml is lying inside the bladder because the urine is continuously coming from the kidneys also. In case of BPH, because of the prostatic enlargement, we can find this post-void residue to be more than 100 ml also, which is considered as significant. We can also assess the serum prostate-specific antigen, which is a serine protease. It is secreted by the prostatic epithelium only. This PSA is responsible for liquefaction of semen. PSA is responsible for liquefaction of semen. 0 to 4 nanogram per ml is considered as normal. More than 10 nanogram per ml is suspicious of cancer, and more than 20 to 35 nanogram per ml is considered for advanced prostate cancer. What should be done in the treatment of these old gentlemen? What we want to achieve? We want that they should be able to pass urine normally. They should not develop any complications. If the patient is having only mild symptoms, if there are no complications, then we can treat them with medicines. But if the patient is having severe symptoms or there are any complications, then we have to treat these patients with surgery. So it depends on the presentation of the patient, mild or severe. If only mild symptoms, then we give medical treatment, medicines, and the medical treatment of choice is selective alpha-1A blockers. This was a question in the recent exam. Here we give tamsulosin, or we can even give alfuzosin. Please remember, beta, these selective alpha-1A blockers, they just relax the internal sphincter, they just relax the prostatic urethra. Because of this, the urine flow improves. For example, if I just take you to that video once again, and herein what we are doing with the alpha blockers, just have a look here. The prostatic urethra is narrow. Now when you are giving the alpha blocker, beta, what is happening?
In the prostate and bladder neck, thus relieving the blockage of urine flow. 5-alpha reductase inhibitors.
Basically, moral of the story, beta, if the prostate is like this, patient is having poor flow, mild symptoms, that means no complications, nothing. We have got plenty of time. Medicines are definitely going to take a long time. When you give these alpha blockers, they are not the medicines which reduce the size of prostate. They just relax the prostatic urethra so that the prostatic urethra widens. I hope this is the impact what is happening. Before alpha blocker, after alpha blocker. Just focus on the diameter of prostatic urethra before alpha blockers and after alpha blockers, right? So that is how these alpha blockers help in improving the urine flow. While 5-alpha reductase inhibitors, 5-alpha reductase inhibitors will be the medicine which would be reducing the size of the prostate, like finasteride and dutasteride. These will be the medicine which will be reducing the size of the prostate. While alpha blockers, they simply improve the urine flow by relaxing the prostatic urethra. if suppose the patient is presenting with severe symptoms or there are some complications like hemorrhage, retention of urine, bilateral hydronephrosis, sometimes maybe recurrent UTIs, sometimes urinary bladder stones, sometimes urinary bladder diverticulas, which we can understand better if there is a traffic jam due to prostate, the proximal people are getting dilated and the chances of stasis infection, stone formation, diverticular formation would be high. So if there are severe symptoms or any of these complications, we cannot wait for the medicines to act because they are going to take a long time. So we need to do surgical intervention, and the surgical treatment of choice is TURP. TURP, this is transurethral resection of prostate. Transurethral resection of prostate. This is what we can do. This provides a fast improvement. We can use green light laser enucleation of prostate. We can use holmium laser evaporation of prostate. These are the other modalities apart from TURP which can be used in the treatment of BPH. Herein, I would like you to see that video once again, that how the TURP is done. This is the endoscope. Now just imagine beta, this is the cystoscope which is actually being passed through the urethra into the bladder, right? That is why we call it a cystoscope. There are side channels through which we can pass the instruments. Another important thing I would like to tell you beta, when you are passing any endoscope into the urethra, normally right now when you are sitting, your urethra is collapsed like this. If somebody tries to pass an endoscope into your urethra right now, since the urethral wall is collapsed, the endoscope is going to hit the urethral wall and this is going to damage your urethra. It is when you are passing urine, जब हम urine pass करते हैं, at that point of time the urethra opens up like this and the urine comes out. We want the same story when we are doing endoscopy. We want that when we are passing the endoscope, the urethra should be like this. We cannot ask the patient to pass urine when you are doing the endoscopy. So what we do is we take the help of some irrigation fluid. You are seeing two pipes here. One pipe is for fluid inlet, another pipe is for fluid outlet. Whenever endourological procedures have to be done, we have to push some fluid which goes inside like this, out. With the fluid on, we push the endoscope into the urethra, and as the fluid is going inside, it widens the urethra, and that is how you can advance your endoscope without causing injury to the urethral wall. Now what happens beta when you're doing the TURP, when you're trying to resect the prostatic chip, when you're doing this, it is not only the prostatic tissue which is being resected, but obviously there are a lot of blood vessels which are being resected. So when the fluid is passed here and the veins are getting open up, then the fluid is going to get absorbed into those veins. Now when the fluid gets absorbed into those veins, then more fluid will come into the circulation. These are old people. The heart may not be able to tolerate such high volume load and the heart can fail. Congestive cardiac failure can occur after TURP. Also beta, if suppose we are using water as the irrigation fluid, as we are cutting through the veins, the water is entering into the circulation. More water going into the circulation will dilute the important ions like sodium. Dilutional hyponatremia will occur, and if the sodium levels in the blood goes drastically down, the patient may go into altered sensorium, and this is called as water intoxication syndrome or TUR syndrome. It is because of this reason we don't use water as irrigation fluid in TURP. We can use glycine 1.5% to avoid this TUR syndrome. Apart from this, sometimes in TURP, because of cutting of the veins, there can be severe bleeding and the patient can present with blood in urine, hematuria. Sometimes what can happen, beta, when the surgeon is resecting the prostatic chip, normally what you are seeing that the dissection is starting just below the internal sphincter. This beta, what you are seeing, this is the internal sphincter. This what you are seeing is the external sphincter. Normally we are starting the resection here, but suppose the surgeon, when he is starting the resection, suddenly a beautiful staff nurse comes and his focus shifts toward the staff nurse and the resectoscope comes here and he injures the internal sphincter. What can happen? There is an ejaculatory duct which passes into the prostatic urethra that is carrying the ejaculate. Normally at the time of ejaculation in males, when the ejaculate comes here, the internal sphincter closes, external sphincter relaxes and the ejaculate passes down. But after TURP, if the surgeon has injured the internal sphincter, when the ejaculate comes here in the post-op period, the ejaculate goes into the bladder. This is called as retrograde ejaculation due to damage to the internal sphincter. And sometimes, beta, if suppose the staff nurse is very beautiful, when the surgeon is resecting the lower part of the prostate, if suppose he also causes injury of the external sphincter, if internal is also gone, external is also gone, then there is no control in the passage of urine. There will be urinary incontinence. So urinary incontinence will occur due to damage to both internal as well as external sphincter. Retrograde ejaculation is because of injury to the internal sphincter. Urinary incontinence is because of injury to both internal as well as external sphincter, right? So let's take a look. What can be the different complications of this surgery? Just a moment. Right. So congestive cardiac failure, this is due to volume overload. TUR syndrome, which we call as water intoxication syndrome. Now this is relevant for 17th of December. If water is used as irrigation fluid in TURP, more water will be absorbed into the circulation because of water going through the veins. Dilution of sodium, dilutional hyponatremia. This will lead to altered sensorium. This is seen if water is used as irrigation fluid. That is why we say that irrigation fluid of choice in TURP is glycine 1.5% and not water. Nowadays, as we are doing green light laser evaporations of prostate, we have got the facility to use bipolar diathermy. And if we are using a bipolar diathermy, then normal saline can be used as irrigation fluid. Generally, in TURP, we are not able to use a bipolar diathermy because the resectoscope is already inside and we have to connect a diathermy on the resectoscope. But in a green light laser, we can use a bipolar diathermy which has got two poles. So the current enters through one pole and exits through the other pole. In those cases, we can use normal saline. In unipolar diathermy, if we use normal saline as irrigation fluid, then sodium and chloride ions interfere with diathermy. So in normal TURPs, where unipolar diathermy is used, normal saline cannot be used as sodium chloride ions interfere with unipolar diathermy. But in green light laser, bipolar diathermy can be used, and if bipolar can be used, we can use normal saline. Then we will not see this hyponatremia. Apart from this, hemorrhage can be a complication. Retrograde ejaculation is a common complication after TURP, and this is due to damage to which sphincter beta? This is due to damage to internal sphincter. Urinary incontinence is due to damage to both internal as well as external sphincter. Because of endoscopy in the urethra, obviously there would be some injury, healing by fibrosis, and that can cause stricture in the urethra. And sometimes sepsis can occur. Sepsis can occur. Infection can occur. So these can be the various complications of BPH. If we just quickly revise this BPH story, it is benign prostatic hyperplasia. After 60 years of age, more than 50% of males suffer from this BPH. The reason for enlargement of the prostate is exactly not known, but there is overactivity of the enzyme 5-alpha reductase, which converts testosterone into 1,5-dihydrotestosterone, which is 20 times more potent than testosterone in causing the enlargement of prostate. There might be influence of some estrogenic steroids as well. The normal weight of prostate is 20 grams. BPH causes enlargement in the transitional zone, which leads to enlargement of the median and the lateral lobes, while cancer of the prostate occurs in the peripheral zone, causes enlargement of the posterior lobe of prostate. When there is enlargement of prostate, the prostatic urethra will narrow and elongate. Patient will present with lower urinary tract symptoms. Symptoms related to storage would be frequency of micturition, more often at night times nocturia, sometimes urgency and urgent continence. Symptoms related to voiding in BPH patients, hesitancy, poor flow. This is the most troublesome symptom. Intermittency, dribbling of urine, and sometimes retention of urine can occur. In our clinical approach in BPH patients, we take the history, we can do a digital rectal examination and feel the enlarged prostate. Investigation of choice will be ultrasound of the abdomen, where we can see the prostate enlarged. We can measure the volume of prostate. We can measure the post-void residual urine. More than 100 ml is significant. Another investigation which can be done is serum PSA, that is a prostate-specific antigen which is secreted only by the prostatic epithelium, can increase in different prostatic pathologies. It is responsible for liquefaction of semen. The normal value of PSA is 0 to 4 nanogram per ml, more than 10 suspicious, more than 20 to 35 suggestive of advanced prostatic cancer. In the treatment of BPH, we want to relieve the symptoms of the patient depending on whether the symptoms are mild or severe. If mild, we can treat them with medicine, and the medical treatment of choice would be selective alpha-1A blockers tamsulosin, L-fifty-zocin, because they relax the prostatic urethra and improve the urine flow and improve the patient's symptoms. We can also use 5-alpha reductase inhibitors, which can reduce the size of the prostate. If the patient presents with severe symptoms or complications like maybe hemorrhage is there, retention of urine is there, bilateral hydronephrosis is going on, maybe recurrent UTI, stone, diverticular formation is there, then we have to have a quick relief in these patients. We cannot give medicines because they are going to take a long time for providing relief. So in these situations, we have to do surgery, and the surgical treatment of choice is TURP, that is transurethral resection of prostate. We can also use green light laser evaporation of prostate or holmium laser enucleation of prostate. Whenever we are doing prostatic surgery like TURP, there can be some complications like congestive cardiac failure. There may be TUR syndrome or water intoxication syndrome. If water is used as irrigation fluid in TURP, it can cause dilutional hyponatremia, which leads to altered sensorium. It is for this reason we don't use water as irrigation fluid. The irrigation fluid of choice in TURP is glycine 1.5%. Now with the advent of green light laser evaporation of prostate, if we are using a green light laser, we have the option of using a bipolar diathermy. And if bipolar diathermy can be used, normal saline can be used as irrigation fluid. When we are doing TURP, there is risk of hemorrhage. There is risk of damage to the internal sphincter, which causes retrograde ejaculation, which is very common, seen in 65% of patients after TURP. If we damage the internal as well as the external sphincter, the urine control will be lost and urinary incontinence will occur. Stricture urethra may develop after some time of operation because of healing by fibrosis, and infections can occur in TURP. Right. So this is the story about BPH. Now, if we move towards the groin area, that is the story about the hernias. Let me just have a quick check. I hope we are not missing out on anything here. We have talked about this story, 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 we have talked about the inflammatory bowel diseases, diverticulosis of colon, we have talked about the retention of urine, the bladder urethral trauma, BPH story. Now we are coming to the groin area, and then we'll be discussing the scrotum area, the testis, penis, the rectum and anal canal. Great. So if we just try to focus in the hernias, basically, to try to understand these hernias, the mechanism is very simple, beta. Whenever there is high pressure inside, or there is weakness of the supporting wall, or there is a defect in the supporting wall, then because of the high pressure inside, that story can start coming out through weak wall or through defect in the wall. Protrusion, abnormal protrusion of a viscus or a part of viscus through a weakness or defect in the wall which contains it is called as a hernia. In Hindi, जब भी अंदर का सामान बाहर आने लगे, या तो दीवार में कोई कमजोरी है या दीवार में कोई छेद है और अंदर का प्रेशर अगर ज़्यादा है तो उसकी वजह से अंदर का सामान उस कमज़ोर दीवार में से या दीवार में जो छेद है उससे बाहर आने लगेगा, उसको अपन हर्निया बोलते हैं. We can find these hernias at so many different places inside the body. Like the commonest hernias what we come across is in the inguinal region. We can find these hernias in the femoral hernias. We can find in the umbilicus umbilical hernias, paraumbilical hernias, epigastric hernias, lumbar hernias or incisional hernia. Wherever operations are done, wherever we have made the incision, we can come across these incisional hernias also. Now, why inguinal hernia is so common. So look at me on the screen, beta. Right now, you might be sitting, right? So if you are sitting, then the entire pressure of your abdomen is borne by the lowermost part of your abdomen, right? So when you are sitting, beta, the entire pressure of your abdomen, just a moment, right? The entire pressure of your abdomen is falling onto the lower part of the abdomen. And unfortunately, beta, God has given a weakness in the lower part of our abdomen in the form of inguinal canal. And whenever the intra-abdominal pressure would be high, the intra-abdominal contents may try to force themselves through this inguinal canal. And that is how the inguinal hernias occurs, right? Now, what can be the different stories related to high intra-abdominal pressure? Obesity, overweight, the pressure inside would be high, constipated individuals straining at stools, traffic jam in the urethra, straining during micturition, all these, smokers, coughing all the time because of lung issues. So anything which increases the intra-abdominal pressure, that forces the intra-abdominal contents to move out through the inguinal canal, right? Femoral hernias are 4 times more common in females. There is a risk of strangulation in femoral hernias. Any hernia where neck of the hernial sac is narrow, then the chances of strangulation will be high. Neck means what? Suppose if we just try to understand the story of inguinal hernias. Now look at me carefully, beta. If suppose I say that this is my inguinal canal here, right? This is the pubic symphysis, and almost the half in this area, the medial side, is the inguinal canal. If we just try to take a look at the anatomy of the inguinal canal, right? Now here in beta, if suppose I keep this here and suppose this is the inguinal canal, and you take a look at the structures here, on the front there is skin, then there is subcutaneous tissue, then there is external oblique aponeurosis. As soon as you cut the external oblique aponeurosis, you actually enter into this inguinal canal. Suppose I cut this external oblique aponeurosis, then I am inside the inguinal canal. As soon as you enter inside the inguinal canal, I am inside the inguinal canal. In case of males, there is a spermatic cord. So there is a spermatic cord in case of males, right? And in case of females, this is the round ligament of uterus inside the inguinal canal, okay? Here in the external oblique aponeurosis, on the medial side, there is a triangular defect which is called as the superficial inguinal ring or the external ring. While if you go inside the inguinal canal, now this will be the posterior wall. This will be the posterior wall of the inguinal canal, right? So on the posterior wall, this is actually formed by the fascia transversalis, or you can say transversalis fascia. And on the medial side, on the lateral side here, there is a U-shaped ring which is called as the deep inguinal ring. Okay? If we just try to rewind the story, the inguinal canal, anterior to posterior, skin, subcutaneous tissue, and external oblique aponeurosis. On the medial side, in the external oblique aponeurosis, there is a triangular defect or an opening which is called as the superficial inguinal ring or the external ring. As soon as you cut the external oblique aponeurosis, you go into the inguinal canal. There is spermatic cord in males and round ligament of uterus in females. The posterior wall, what you are seeing of the inguinal canal, is formed by the transversalis fascia, wherein laterally there is a U-shaped defect or a ring that is a deep inguinal ring. Herein, the floor of the inguinal canal is formed by the inguinal ligament, and the roof of the inguinal canal is formed by the arching fibers of transversus abdominis and internal oblique, that is the conjoint tendon. So this is just about the anatomy of the inguinal canal, which is discussed nicely in detail in the anatomy classes, right? Now another thing which I would like to tell you, beta, just medial to the, here what you're seeing, this is the deep inguinal ring, and just medial to the deep inguinal ring lie the inferior epigastric vessels. There are inferior epigastric vessels which are lying just medial to the deep inguinal ring. Okay, in this inguinal canal we can find indirect inguinal hernia and direct inguinal hernia. Indirect comes out from the deep inguinal ring. Direct hernia comes out from the transversalis fascia in this area. Just look at the screen, beta. This is the inferior epigastric vessel. Here is the deep inguinal ring. Indirect hernia comes out through this. So indirect hernia is lateral to the inferior epigastric vessels. Direct inguinal hernia comes out from this area. This is medial to the inferior epigastric vessels. This is the Hesselbeck's triangle area. So in the inguinal hernias, there is a indirect and there is a direct inguinal hernia. Indirect inguinal hernia is much more common than direct. This is more commonly seen in young people, while direct is more common in elderly people. Indirect comes out through deep inguinal ring. Direct comes out through Hesselbeck's triangle. Indirect is lateral to inferior epigastric vessels. Direct is medial to inferior epigastric vessels. Indirect hernias, they protrude in a downward, forward and a medial direction. So indirect hernias, they protrude downward, forward, medial direction, and they have a high chance of going into the scrotum. So indirect hernias which are moving like this can go into the scrotum. But direct hernias, they usually protrude like this, सामने की तरफ आते हैं. Direct hernias, they protrude in a forward direction. So the chances of going into the scrotum for direct hernias are less, right? This is a basic difference between indirect and direct inguinal hernias. Let's see what all is written here. Most common hernia what we come across is a indirect inguinal hernia. Most common hernia, just give me a moment. Right, beta. So, most common overall hernia is indirect inguinal. Most common, just a second. Right. So most common hernia in young males, it is indirect. Elderly males, it is direct. Femoral hernia is 4 times more common in females, and most common hernia to undergo strangulation is femoral. Any hernia where the neck of the hernial sac, suppose deep inguinal ring, if the hernia has to come out from this deep inguinal ring, suppose, and if this ring is tight, then whatever has come out, this tight ring will put pressure on the blood supply of that part. So the chances of ischemia and strangulation will be high if the ring or the neck is tight. Now this is the difference between indirect and direct inguinal hernia. Here in beta, this what you are seeing, suppose I say that this is the inguinal canal. This is the inguinal canal, suppose. Now here in this inguinal canal, there is a triangular defect. This is called as the superficial inguinal ring or the external ring. There is a U-shaped defect. This is the deep inguinal ring. And here lie the inferior epigastric vessels. Any hernia which protrudes through the deep inguinal ring, that will be called as indirect. And hernia which protrude through the Hesselbeck's triangle, this area, that will be the direct inguinal hernia. So if we carefully try to see, indirect hernia is more common, direct is less common. Young people have more chances of indirect, elderly people have more chances of direct. Indirect hernias protrude through deep ring, direct hernias protrude through transversalis fissure or Hesselbeck's triangle. Relation with inferior epigastric vessel, indirect hernia is lateral, while direct hernia is medial to the inferior epigastric vessels. Direct hernia is medial to the inferior epigastric vessels. Direction of protrusion, indirect hernia protrude downward, forwards and medially, so the chances of going into the scrotum are more common. While direct hernia protrudes in a forward direction, so chances of going into the scrotum are less. Landmark to differentiate indirect from direct inguinal hernia, as we can see, this is the inferior epigastric vessel. Inferior epigastric vessel. Here only we should know that femoral hernias, they come out through the femoral ring here, right? So if the hernia is coming out through the femoral canal, that is femoral hernia. Now if we try to compare this landmark, what you are seeing beta, this is the pubic tubercle, suppose. This is the pubic symphysis. Here would be the external ring. This is the pubic tubercle. This is the anterior superior iliac spine. So inguinal hernias usually present as a bulge here, which is above and medial to the pubic tubercle, while femoral hernias present as a bulge here from the femoral canal, which is below and lateral to the pubic tubercle. So to differentiate inguinal from femoral hernias, we take the help of pubic tubercle. And as we can see here, inguinal hernia is above and medial, while femoral hernia is below and lateral to pubic tubercle. So this is a broad concept about the indirect, direct inguinal hernias and the femoral hernias. There are more classifications which we have to discuss. So what we'll do is, we'll call this session here only, and then most likely we would be seeing somewhere at around 6 p.m. As of now, the scheduled timing is 6:30 p.m. But if there is anything by which I would be making a little early, I will definitely be informing you. Thank you very much for your patience. Thank you for avoiding your lunch break till almost 3:30. Thank you very much. God bless you all. Wish you all the best. Keep on pumped up like this. Keep on focused like this. You are doing the right thing. Keep believing in yourself. Take care. Bye-bye.